4, 3, 2, 1. We are live.
Thank you, Dr. Ashok Shyam, sir. We have all the speakers for this webinar on the board. And I would like, first of all, I would like to invite Dr. Nirmal, who is the Secretary of Jharkhand Orthopedic Association, to welcome all the speakers and participants of this webinar. Over to you, Dr. Nirmal.
Thank you. Thank you so much, Dr. Manish. On behalf of Jharkhand Orthopedic Association, it's my privilege and honor to welcome all the faculties on board and also the team of PG teaching program for Jharkhand Orthopedic Association. It's really going to be quite fruitful, I'm very sure, with the kind of plannings which we have put in, not only just for this webinar, but for the future as well. And it's going to be a series, and I'm looking forward to support and blessings from faculties who are right now on board with us. And we are very much confident and hopeful that in coming time, this program is going to be really successful in terms that all postgraduates will start looking forward to it. And with that short note, I just wish all the best to the team, which has put in so much of efforts. And again, welcome all the faculties on board. Thank you. Thank you so much.
Thank you, Dr. Nirmal, for your kind words. We have 4 scientific sessions of half an hour each. We have as speakers Professor Dr. Lalit Maini, sir, from Maulana Azad Medical College, New Delhi. We have Dr. Tarun Goyal, who is additional professor in AIIMS, Bhatinda. We have Professor Dr. Anil Bhat, sir, who is professor and head of the Department of Hand Surgery in KMC Manipal. And we have Dr. A.K. Pal, sir, who is professor and HOD in SSKM Medical College, Kolkata. We have moderator Dr. Sobi Das from Ranchi, Dr. Virendra from Bokaro Hospital, and myself, Dr. Manish from AIIMS, Devghar, who will be moderating the different session. To start the scientific session, I would like to invite Dr. Sobi Das, who is assistant professor in RIMS Ranchi, for the first session. Over to you, Sobi Das.
Thank you, sir. I'm very happy to be part of this nice venture. And this webinar is, I think this webinar is being conducted at a very critical juncture. I mean, while the first year PGs have recently joined and exams are looming for the third year PGs. So residents often ask, I mean, what is expected from them during the residency? So today we are very pleased and excited to have Professor Dr. Lalit Maini, sir, he will share his opinion and guidance and guide the residents. He needs no introductions. He is an academician par excellence. He is the director professor at the prestigious Maulana Azad Medical College in New Delhi. He is also the editor of the prestigious Indian Journal of Orthopedics. He was also the immediate past president of Delhi Orthopedic Association. He has more than 100 publications and several book chapters to his name. So please join me in welcoming Professor Dr. Lalit Maini, sir. Over to you, sir.
Am I audible?
Yes, sir.
Thanks a lot. Thanks for those kind words and a very kind introduction. And I would like to congratulate the Jharkhand team on thinking of this and initiating a PG series, in fact, as I understand. So good evening, everyone. I'm going to be talking on expectation from orthopedic PG students from the Indian subcontinent. And you would know that the PG degree in Indian subcontinent is of 3 years, the MS Orthopedics. And as you can see, the stepladder type of a picture which I have put on the first slide, which has more than 3 steps. It has actually 6 steps. And in the next 20 minutes, I will like to share with you certain objective things and certain subjective things which are connected towards the expectation from an orthopedic PG student as far as the training curriculums are concerned. My disclosure would be that I have been teaching in University of Delhi for the last 2 decades. And so a lot of my thoughts and content comes from the curriculum in this university. So when you think about expectations, there are quite a few stakeholders in it. The student obviously is the key, and the person or the main person who's going to get affected is the patient. The student is guided by the mentor, or you can say the teacher, where he's getting trained to give treatment to the patient without any harm caused during the teaching curriculum. And if you look at the same expectation at large, the society comes in. The student, the mentor, the patient, all three have a family. The family lives in a society. The society forms a state, and you have your own understandings, religions, acceptance, and rejections of scenarios. So let's focus on what we would be aiming from a curriculum in post-graduation in orthopedics at the end of 3 years. So as I said, certain objective things, there would be certain essentials, and there would be certain things which are desirable. And these are the things which cover the art and science of becoming an orthopedic surgeon. So the most important thing I would consider it as a logbook, which is gradually gaining importance and is becoming a regular phenomenon in most of the universities. And if it is not, it is high time that we get on to it. The second essential that a postgraduate does during the 3 years is a thesis, in which he does a research thesis in which he would understand basically how to do a research in orthopedic practice. And then towards the end, he would definitely have to clear an exam. This again is changing. A lot of universities are getting an internal assessment. So a gradual build-up according to the curriculum, which is detailed in that university, they would be deciding their own internal assessments. So internal assessments are increasing value. And then there would be other things which are the journal club, the seminar, the conference presentation, and publication. On the right side, I've put 2 bold essentials, which are books and journals, which obviously a student entering a postgraduate activity needs to go through. So it's a lucky period of life where the education is becoming more and more structured. You can debate structuring has its downsides also. But then our Delhi University comes out with a list of books which are recommended and which are changed time to time according to what the curriculum committee feels. And Google and internet is helping disseminate knowledge. But I think as a postgraduate student, you need to be studying and going through the recommended books and journals. There is a big change which is happening in medical education, and that is competence-based medical education. It is already taken a good structure as far as the undergraduate MBBS training is concerned, and it is also knocking on the doors of postgraduate training. And I see it coming, maybe it's already there actually. And as you can see, it actually targets delivering healthcare without causing harm to the patient. And it involves all things like skills, knowledge, attitude, experience. And it's just not only covering up certain topics. In the whole process of the expectation, something which is disappearing is Guru Shishya Parampara. And I would feel, and as would most of the teachers feel, that this is one of the very, very important part of our culture, which has an immense potential, especially in surgical training. The globe has realized this fact, and if you go through literature, you will find huge number of articles talking about mentorship. So the Guru Shishya Parampara has been designated the terminology of mentorship, and which now is very well accepted, especially in surgical field and of course in orthopedics. And it has its value because it is a passing on of art and science. Science could be understood going through literature, but art needs a guru to take you further. So I think the postgraduates who are listening to this talk should realize this, and it's not just a term, but it has a lot of value on what you reach maybe at the end of 5 years or 10 years from now. So with the increasing number of postgraduate students in each college and in each university, there is a change in the way probably the education can be imparted. And because of the sheer numbers, the expectations from the teachers have also got modified. That is where to handle the numbers is coming in the structured curriculum, which could sort of chase up and make sure that each person who goes through the postgraduate training has enough exposure and comes out as a good orthopedic surgeon. So let's look at a part of this talk which is more objective, which give you some direction on where you should be moving. The goals and objectives of orthopedic surgery is developing the ability to evaluate, diagnose, stabilize, and treat the orthopedic patient. I keep telling on my rounds that postgraduate students are here for learning. And at the end of the day, healthcare delivery is the responsibility of the consultants and the senior residents. So in PG, you need to give a lot of emphasis on evaluation, diagnosis making, and taking early care, becoming a part of the team, stabilizing and delivering the orthopedic care. The postgraduate course is a self-study. It's an in-training course. And these two terms are very important. The student is expected to know the theory part of the orthopedic practice and patient care. The training has three distinct parts: the theory part, the professional behavior part, and the learning to do the procedures, which I was talking about, the art of orthopedic surgery, which comes under the umbrella of a guru passing on his experience and decreasing the number of problems you can do during your own training. So remember, it's a self-study course, and if you're being coaxed to understand and learn this, you're on the wrong bus. So you can see a fluoroscopy image on the right, which is showing a wire in the neck of the femur. And you would know the entry point, you would know the direction, you would know the angulation. But then it takes some skill and practice to get it right on there. So it's a very, very well knitted sort of a thing. And these are not exclusive of each other. In fact, they are inseparable at any given point of time. And the course intends to develop the entire professional personality of the student. It's you are actually maturing from a doctor to a specialist. The curriculum is constructed with an objective to develop all three domains of learning in the student, so that, as in this example, you could put the screws after reduction of the fracture in the most appropriate position. So most of the universities are now designing a program in which you have targets for year 1, 2, and 3. And then the year 1 again is divided into maybe 3-month or 4-month modules. And our university follows this. It has a 0 module, meaning the first year when the student joins in, there is an orientation time where we emphasize a lot on self-care. We put it in red because we've observed in the past few years that this becomes a very, very important thing at the beginning of this change from an undergraduate intern to a postgraduate training program. Communication skills is emphasized because here is when you start interacting with your colleagues, with the paramedic staff, with the patients in the interest of the patient care. Clinical workstation learning, cognitive plus non-invasive psychomotor skill acquiring, small group methods, most of the universities and the colleges have unit-based teams, so the training goes on in that way. And there is always a requirement of a self-study. So in the zero module, if you, at the end of the zero module, you would be required to know plaster casting theory and hands-on on plaster techniques, primary splintage, types of splints, wound care and dressing techniques, hand wash techniques for OT, and documentation, including consent taking. It is thought of that it is a medical clerkship, but it is training you on documentation, and you realize with time how important it is. So the module 1 of first year, now these dates are according to the normal schedule of program starting in May. So the module 1 would be the August, September, October, where you would be exposed to research protocol, and you would be desired to design a protocol for your research thesis. The learning the methodology of preparing a presentation, targeted searches for a particular topic, and acquiring new intellectual skills, basic care of trauma patients in these first 3. And in our curriculum, we actually also keep telling them the resource material which could be useful to them. So at the end of this second module, you would be required to be supervised application of skeletal traction in lower limb, diagnostic aspirations under supervision, getting ready for assisting an operation, familiarity with the radiological monitoring in the OT, wound debridement under supervision. So you can see gradually there's a build-up happening in which you get into more and more complex scale. So the next module between November and January will be focused on use of biomechanical principles, region-specific trauma, or maybe can start from upper limb in some universities, some from lower limb, and understanding the principle of fracture fixation and the practical use. The AO manual is one book which comes in at this time. And at the end of this module, you would be expected to be assisting suturing of wounds, pressure dressings, drainage tube removals in the post-op patients, removal of simple unipolar biplanar external fixator, assisting removal of ring fixators, skin graft techniques, dressings, primary preparation for parts for major surgeries, familiarity with image intensifier, and assisting application of external fixator. So now you're gradually getting into the operating room as maybe the second assistant. And in the module 3 of the first year, which is February to April, you start presentation at scientific meetings, introduction to non-trauma conditions, maybe regional trauma, applying the basic knowledge to orthopedic diseases and formulating the aim of treatment. So you're gradually getting into the role of decision-making now, and also starting presentation at various forums. So at the end of this module, you are assisting emergency trauma surgery. You are taught about types of surgical knots, familiarity with suture techniques for different tissues, documentation of a patient with neurological deficit on specified charts. So neurological assessment is starting now, assisting close reductions of simple dislocations. And that's what is expected in the first year of your residency, which is looks pretty comprehensive, and it is to be attained on your own as well as by the guidance of the unit where you're posted. And as you get into the second year, complex regional trauma, office orthopedics, osteoarticular infection, all these things come in. And the first module, at the end of first module, you would be required to assisting local infiltration for common painful conditions like tennis elbow. So you're starting minor procedures, assisting split thin skin grafting, familiarity with special views of pelvic acetabular trauma, assisting arthrotomies for acute arthritis, septic arthritis, assisting a routine surgery. So you're gradually moving from maybe the second assistant to the first assistant, getting familiar with common implants used in trauma surgery. And as you move on to the second module, which is August to October, you start getting exposed, or you start looking into other parts of orthopedics like oncology, principles of prosthetics, endoscopic surgery. So you would be expected to know this and learn or read or see, even if it is not happening in your institutes. And at the end of this module, you would be expected to have assisted core biopsy, getting familiar with basic AO instrumentation, and the various other details. So I would be happy to share the curriculum of University Delhi, which you can use as a module in your various colleges or institute and modify it according to your requirements. Module 6, polytrauma, complex upper limb trauma, osteoarticular fractures. And here you start attending conferences. It's in the curriculum that you're supposed to be attending and presenting in conferences. And then the type of surgery become a bit more complex, tibial fractures, ligamento-taxis, fasciotomies, assisting traumas like hemiarthroplasty. And module 7, which is coming to the end of second year, you start your preparing your thesis, and thesis writing becomes an important part at this module, and also assisting miscellaneous elective surgeries. So the last year, which is the third year, again divided into modules. You would go regional orthopedic modules, like we start our focus with hip, everything about hip, expertise in clinical assessment, investigation, concepts, procedures, documentation of hip cases, and examining and making a diagnosis. So you would, at the end of the first module, at least tick up everything connected to this module in your logbooks. In the second year, you move on to second important long case, which comes in the exam, which is spine. So spine surgery, neurological and mechanical competency spine surgery, orthosis of spine. And by the end of this module, you should be assisting major spine surgeries, assisting cervical spine surgery if possible, supervised open and closed intramedullary naring, closed reduction in percutaneous normal. So you're getting on hands-on as a first surgeon at times. And then coming towards the end of the third year, where you get into the miscellaneous, the congenital and other parts of orthopedics, and you would be required to know about such conditions and try to look at them in the clinics and understand how they need to be managed. Clubfoot, a very important thing, you get to start seeing them year 1 itself, but then by year 3, you would be probably the main person following up a case. So last module of year 3, you're going to be revising whatever you have done in your first 3 years, and you would be looking at certain things which were not touched, like rehabilitation, and you would be preparing for your exit exam, which invariably everywhere is a theory which has 4 theory papers and a practical exam. And the practical exam has a long case and 3 short cases and 4 table vivas. So you need to be aware of this so that you are preparing day 1 and you have a bird's eye view of what you're going to be doing. But if during your 3 years of residency, you are the mice and your mentors and teachers have been only chasing you to get you on track, I can tell you, you are on the wrong bus. It'll never, you might pass in the MS orthopedic exam, but you fail in the exam of life to deliver orthopedic care. So I think you should be the cat and chasing your teachers and seniors to impart their experience and knowledge to you. So the key to success, I feel, in orthopedic residency has a A, B, C, D, E to it. A is availability and appearance. B is behavior and body language. C is competence and knowledge. D is documentation, and E is ethics. And I can tell you, A and B has a very, very important role in becoming a good orthopedic resident, so that you can get your degree and then become a very, very good senior resident. So to end my talk, I would say it is not about capability only. All of you who join orthopedic training are good students because you finished your MBBS, you the cream of society, you cracked the NEET PG and got the best ranks to get this. So it's about the mindset once you get onto the horse and you decide where you want to take your future. So try to give value to this opportunity that you have got through the MS Orthopedic curriculum. And I think it has an objective part to it now. So if you chase up the objective part, fill up your logbooks, make sure the targets which are drawn out are ticked, you will be on the right road. Thank you very much for your kind attention, please.
Thank you so much, sir. That was very insightful, and it gives a bird's eye view of the whole residency program, and also emphasized about having proper mindset towards the program. And the residents will surely benefit by this invaluable, valuable suggestions. Now we can move on to the question answer session. One question I have, sir. How much responsibility should be allowed to residents during the residency program regarding patient evaluation and management?
I think most of the institutes, the resident is the first responder, whether it is the emergency or it is the outpatient or it is an inpatient. And as I always say, a postgraduate student is only learning, and the responsibility of the healthcare delivery totally lies on the senior resident and the consultant. So if you ask me in an objective way, their responsibility is actually zero. However, to get trained, they have to be a part of that activity, and that is where the teachers gradually pass on responsibility, evaluating the competence of each person, and ultimately knowing the responsibility of care lies in the consultant and the senior resident.
Yes, right, sir. So another question is, so can you enumerate regarding most important course or any conference to be that should be attended during residency, during 3 years residency?
That's a very easy question for me. So the simple rule is you need to attend at least 4 orthopedic events per year, and that makes it 12 in 3 years. So as you go module wise, make sure you're doing at least one per module, and you have to participate in your city, state, and national conferences. So if you are in a city like Ranchi, you have to participate in the conference being done in Ranchi. And then you must be having an annual conference of Jharkhand. So you must participate there. And then you would always have an Indian Orthopedic Association annual conference. So I think the city, state, and the national conferences should be attended by postgraduates. When you rub your shoulders with experienced mentors, it gives you a different type of education which cannot be got by doing anything else. So try to encourage your residents to attend at least 4 meetings per year. The maturity about specialty meetings, I don't think would come during post-graduation. It might come if you're lucky that your mentor is an expert or a stalwart like Dr. Bhat in hand, and your thesis again in hand. So by the end of 3rd year, maybe you might be attending the annual conference of Hand Society.
Yes, sir. My next question is somehow related to the first one. Basically, during college selection, during counseling, MBBS graduates, they often decide regarding how much hands-on training they would get in a particular college. That was a very important deciding factor. So, I mean, what is your opinion? How much hands-on training should be allowed to them as a individual surgeon?
It's a very tricky question. It's not only hands-on. You see, if you get back to the postgraduates, there are multiple things which they take a call on by deciding. The bond is one thing, the salary is another thing, the city is another thing. But I would just address the hands-on, which in the residents' word is cutting. How much cutting are you doing? Now it's become a recent fashion that's becoming a deciding factor. But I keep telling my residents, if you are sincere and doing well, you will always get hands-on wherever you're working. And it's not about the numbers. The numbers don't count at the end of the day. At the end of 5 years after joining PG, most of the PGs would have done similar amount of work. So I don't think numbers is a big issue. It's a balanced decision taking multiple factors into consideration. So another way of putting this is that if you're made cowboys and given Sten guns day one and you fire in the open without supervision, that's also not a great idea. So there has to be a balance between hands-on as well as the training. But then the only thing I think which has the biggest advantage or a disadvantage is the numbers which attend your institute. For me, the clinical material is most important. Like I said, you need to understand how to evaluate, diagnose, and stabilize patients. So if you have numbers, that is the right institute. Hands-on and cutting comes along in life. You're going to be doing that throughout your life.
Yes, sir. So, sir, the last question. Sir, what's your opinion? To these residents, they need to adapt to the skills of physiotherapy, occupational therapy, and prosthetic and orthotics. How much time should be devoted to them, and should this be included in the curriculum?
Yes, of course. We had it in our residency. I would agree that these branches have diversified so much that they have a specialized role now. But then if an orthopedic resident has not visited a physiotherapy or an occupational therapy department during his residency, I think he's at a loss. If he doesn't understand a brace or a prosthesis, how it is prescribed or how it is taken care of, I think he's at loss, because this is directly connected to patient care. The aftercare or the care in conservatively managed patients depends upon a lot on these ancillary branches to orthopedics, and they should. I encourage my residents to go and visit industries also where the implants are made. You're neither going to make implants or modify them, but then once you go through the whole process of how things are done, your understanding of the whole care improves. So I think it should be mandatory, and we can't get off the table viva of orthosis and prosthesis from PG exam. I think stick with it. It helps patient care. It helps your practice in life.
Yes, sir. So I guess the residents must have got the answer, because many residents ask, what is an orthopedic resident sufficiently trained and ready for independent practice? I guess they now understand when it's a long road. So thank you so much, sir. I can extend our appreciation, and thank you for providing for your valuable time. Thank you so much.
Thank you. Thank you.
I guess we can now move on to the next session. The next 20 minutes, the residents will get to know what and how to read during the residency. So I now welcome Dr. Virendra Kumar sir to moderate the next session.
Thank you. Thank you, Dr. Shovik. Am I here? Audible? Hello? My voice is clear?
Yes, Dr. Virendra, your voice is pretty clear.
May I start?
Yes.
Yeah. Thank you, Dr. Manish and Dr. Shovik. Good evening to respected seniors, teachers, and my colleagues. It's my privilege to ask something about Dr. Tarun Goyal, sir. He did his MBBS from AIIMS and MS from PGI and DNP also, and MCS from UK, FSCS and FRCS from Edinburgh, UK. At present, he is working as an additional professor in orthopedics, AIIMS Bhatinda. He has more than 120 publications at present and citations more than 1200. It's a huge figure. And H index and I index is 19 and 30 respectively. He has more than 70 guest lectures and paper presented more than 60 and conferences organized near about 8. And he is working on research projects, intramural and extramural, and completed near about 6. His achievements are fellowship in joint replacement and arthroscopy in 2011 and secret diploma in 2011, his fellowship in knee and shoulder from Germany in 2013 and 16 respectively. He again did his fellowship in shoulder surgery from Italy. And he has multiple traveling fellowships like British Orthopedic Association and Ludhiana traveling fellowships. His AO Trauma Fellowship also in 2017. He is founder member and faculty in charge in Bond Bank Rishikesh AIIMS and editorial board member also in IJO. His membership of having British or Indian Orthopedic Society, CCOT, AO Trauma, Indian Orthopedic Association, Delhi Orthopedic Association, and North Zone Indian Orthopedic Association. His topic is over the how and from where to read theoretical and practical clinical knowledge during the residency period. And I hope so. This is very much applicable to all the PGs and DNB. And most of the time, our PGs and DNB gets puzzled in complete 3 years from where to read, how to get the maximum practical knowledge, where the clinical knowledge we will get more and more. So I hope by this lecture, Dr. Tarun Goyal sir will clear everything. Over to Dr. Tarun Goyal sir. Dr. Tarun Goyal sir, please unmute and come on video. I think some need to show or
am I?
yes sir. Now your voice is not clear. Please check it. The slides are visible, but voice is not very clear.
Am I audible now?
Yes.
Yes, sir, you are audible, sir.
Okay. So if I am clearly audible, should I continue?
Yeah, please go ahead.
Thank you. Thank the Jharkhand Orthopedic Association for having me here, and Dr. Manish for coordinating everything, and also for my introduction. And I'll take up the next topic about where and how to prepare and read for and the clinical parts during the residency. And hello. I think there was some disturbance. Am I still audible?
Yes, sir, please.
Okay. So we are going to discuss where and how to read for the theoretical and the practical examination during the period of residency. There is no straight one answer to where to start for the theoretical and the practical examination. And we are going to discuss broad things. Dr. Dubey, I think there is some disturbance from your side, right? So if we start with when to start preparing. So my advice for the PGs should be that the basic, sometimes there's a conception in some colleges, and many people start believing that you start reading at the end of your residency, just about 6 months before the examination. That's the time that you start opening your books and start reading. It is absolutely not true. Reading and preparation starts not in the last year or your last semester of pregnancy of your semester, but it starts right at the first semester of your postgraduate training. So as soon as you enter the postgraduate training, I'm really thankful to Dr. Maini, who has shown the module-based system and the competency-based system of which has been well developed in last few years and is recommended to be practiced now. It clearly states the modules in the order of hierarchy that needs to be appraised and studied starting from the first year of residency. So it starts right from the very basic topics and is progressing in its level of complexity. So reading and preparation starts not in the final year, but it starts in the first year, because the knowledge has to build up over the next 3 years. And you have to be very regular in your reading. The last months are best kept for revision of the concepts which you have already studied and assimilated during your 3 years course, because it will not be possible for you to read and enough to become a good orthopedic surgeon if you start in the last few months of your training. We cannot recommend a single book or a single set of book that would be sufficient for your orthopedic knowledge. Orthopedics is a huge subject. When you were an undergraduate, all you knew as an in the name of orthopedics was probably a single book or a single textbook of about 400 to 500 pages, during your which was easily readable in a week or 2 weeks time, and that was the basic notion of what orthopedics is. But as a PG, as a postgraduate student in orthopedics, you will realize that it was not even the tip of the iceberg. It was really orthopedics is a huge subject, and there is not a single book that will be able to cover your entire training and the course in orthopedic surgery. They are reference standard books. We'll discuss what are the standard books and what are various other reference books that can be studied during your orthopedic training. But my suggestion would be, whatever you read during your orthopedics training, whatever topic you read during your training, should start with a clinical question in mind or a clinical picture in mind. Because once you read with a targeted question in mind, you will be able to retain the information, you will be able to gather more meaningful information, which will stay for you for a longer period of time and much more useful to you and much more productive reading as compared to a sort of a storybook type of reading of a textbook. For the basic knowledge in trauma, generally for different, if you divide orthopedics, you should be able to see in the first year of your or first semester of your orthopedics training that orthopedics has various subspecialties. For example, orthopedic trauma, then you would also have pediatrics, then you would have spine surgery, then you would have arthroplasty, arthroscopy, then pelvis, oncology, tumors. These are the various subspecialties in orthopedics which needs to be covered from different places during your orthopedic training. It does not mean that you have to read all these books cover to cover, but you need to cover many topics which are essential and are common and are must-know type of topics during your postgraduate teaching. So if you can divide your topics, the topics can be divided as must-know, good to know, and may know. So must-know topics definitely should be covered in absolute detail from various orthopedic textbooks, including the reference textbooks over and above the standard textbooks. So in trauma, generally, we would recommend to read the Rockwood and the Green, and you would also have similar pocket books for your ready reference. For general orthopedics, what is considered a gold standard are the Miller's and the Apley system of orthopedics. Pediatric orthopedics, Texian is the most standard book which is read. But again, these are not inclusive. This is not a way of suggesting that these are the only books on this subject. And let me tell you one more thing, that it may not matter at the end of the day that which book you have read. It will be more important how you have read those books and what was your approach to learning and reading those books. Similarly, in oncology, the Martins Malavar's book is the most commonly read book in oncology. Surgical Exposures by Hoppenfield is a very important book to have right from the beginning of your residency, where you would be able to understand the anatomy of surgical exposures, and is a very ready reference for you even in your operating room theaters, where you can quickly revise the various surgical approach that you would be witnessing during your operating room postings. Tuberculosis of the Musculoskeletal System by Professor S.M. Tully is one of the very good books to read about tuberculosis of bone and joints. Traction and in orthopedics, it deals with various traction devices and orthosis, and is also a very good book to read. A very important thing is clinical examination in orthopedics. So the question may be where to read about the clinical examination in orthopedics. So we may have books like Suresh Prapande, and we also have David Maggie's book on clinical examination. Is a very, very detailed thing to read, and it's not only you cannot learn clinical examination by reading. You actually have to see the patient and actually have to perform on the patients. So it actually the way you deliver your clinical examination in front of the examiner on your D day would be a cumulative effort of reflect a cumulative effort that you have put in for the 3 years of your postgraduate training in the department. You should also understand the pattern of your examination before you are actually started to read about your exam. So in your exam, you would have your theory examination as well as your practical examination. In your theory examination, the most common pattern that is still followed is 4-paper pattern, in which the topics are divided, although they are not absolute waterproof, leak-proof divisions, and you may have topics coming to you in different combinations. The topics may actually be overlapping sometimes, but most of the paper one. So you also know that how can you divide the orthopedics? So it can be basic sciences applied to orthopedics. Sciences would mean about your bone morphology, bone physiology, your anatomy of orthopedics, your surgical exposures, your MRI pertaining to orthopedics, or radiological investigations pertaining to orthopedics, and certain basic topics related to resuscitation, triage, and management of a multiply injured patients. These are some of the most common basic topics that are covered in orthopedics. Then the second comes traumatology and rehabilitation, which covers most of the topics related to fractures, injuries, trauma, the management and rehabilitation of these patients. Then comes the cold orthopedics, or the orthopedic diseases, which may deal with diseases like inflammatory, neoplastic, various pathologies of the bone, arthroplasty. Then paper 4, which may cover the recent advances in orthopedic surgery. So most of the things may have advances, so it does not mean that it will be a regional orthopedics type of thing, but it will have various things which are upcoming, or which are new, or which have a path-breaking application in orthopedic surgery. Then is your practical examination. Practical examination and both theory examination are becoming more and more objective rather than subjective these days. And the mark breakup of most of these examination is becoming more and more objective, and expectation from the candidates is also changing over time. Your long case, it carries maximum marks during your practical examination, but it does not mean that your performance in the long case is the only thing that decides your pass or failure in your practical examination. But long case, basically, the examiner wants to see your approach to a major case in orthopedics. Long cases are generally kept from the hip or the spine regions, and then there are multiple, about 3 short cases that are generally kept in the examination. And these are generally the cases which you would see, for example, deformities, foot and ankle deformities, clubfoot. Then there could be infection or tumors or ligament injuries that are generally kept as short cases. So once you know that what are the basic conditions, common conditions that can be kept as long and the short cases, I would advise you to make a list of the common long cases and the common short cases that would be seen during examination, and maintain that list and ensure that you have presented or you have witnessed the presentation by one of your colleagues of sufficient number of long and the short cases in each category of orthopedics. So almost you should have covered all such cases during your then oral examination or viva examination in orthopedics. It may have about 3 to 4 tables or stations which may discuss surgical anatomy, instruments, radiology, surgical pathology, orthotics and prosthetics, and surgical procedures, which can be discussed during various stations in orthopedics. So it's important to know that during your viva examination have no limits, and viva examination can overlap a lot of topics and a lot of concepts together. So basically the examiner will be able to understand your depth of the knowledge during your viva examination, and such depth cannot be attained by a few months of reading. It will reflect your presence of mind and application of your knowledge during your entire 3 years. So that's what, as a resident, I would advise you that your learning starts from day one. You see the patients, you understand the condition, and you develop the questions about that clinical condition that the patient is having. Make a clinical question in your mind, or understand what you want to read. Go back, search for that topic in your textbooks, and refer to the standard text. Read more about the topic. That will give you more insight of the topic and more understanding of the topic. And even later on, once you go back to your textbooks and read the same text again as a part of your preparation for the module or the final examination, then that is going to help you a lot, because you already have a basic understanding of that topic. And let me tell you that books are not sufficient for your knowledge in orthopedics. Even as an orthopedic resident, you are expected to go beyond the books, and various review articles are, again, review articles from various standard journals, good journal of orthopedics, will give you very good knowledge and insight about common conditions in orthopedics. For example, JBJS reviews, Orthopedic Clinics of North America, E-Fort Open Reviews, Orthopedic Knowledge Update. These are some of the very good texts that you should always refer to while referring to your standard texts. So try to understand the questions that are generally asked in the examination or generally encountered in the clinical scenario during your during the time that you are seeing the patients. Emphasize on these questions while you are reading the particular chapter. For example, if you have seen a patient with the Perthes disease, and you have seen a 6-year-old male boy who has presented you with a Perthes disease with symptoms of 2 months, you want to know, they should be, as a resident, you want to know that how this patient is going to behave, what is going to be the prognosis, what's the best approach in its treatment of this patient, and what caused probably this Perthes disease in this child. So surround yourself with these questions in mind. How this disease happened, what is going to happen further, what can I do for the patient? Then go back to your chapter on the Perthes disease and read about the pathogenesis of the disease, the natural history of the disease, the treatment offered for these patients, and the prognosis of the patient in this of this particular patient who is presenting you with Perthes disease. And believe me, once you read the chapter with this approach, it is going to give you much more understanding. You'll be able to read the chapter much more quickly and understand and grasp a lot from the chapter, which you will retain for a longer period of time than what you would read if you just read the book cover to cover. That does not mean that you do not have to read the topics not covered in the questions. Of course, you have to read, you will be reading the entire chapter, but it will make your, the topics which you have read are like spot welds in your mind. So those topics those are the things which are actually going to keep that topic adhered to your mind. It will not let you slip or forget those concepts and the topics which you have read from that chapter. So try to read the topics same time that you see the patient, and also try to read the topic. You would have seminars and journal clubs in your departments which are presented by you or by your colleague. So attend your seminars actively. Once you attend your seminars, once you have seen your colleague presenting a seminar, then before the seminar you should ideally go prepared, so that once you hear something in the seminar, if you hear and you question what is happening there, you try to go back and read, that is going to retain in your minds. Understand your syllabus and pattern. I would request you all to go back and refer to the NMC curriculum for orthopedics. It gives you the guidelines for competency-based postgraduate training program. So I don't know how many of you would be aware or familiar with this word competency-based postgraduate training program. It basically means that it divides the orthopedic syllabus or the curriculum in various competencies. Competencies means the things which you would know, things which you would perform, and how you perform those things. So it will give you a set of things which it will tell you that you should know these things by the end of your training or by the end of this module. You should be able to perform these things by the end of this training, and you would also have an affective component, which I'm going to discuss later. So it gives you very important things like basic sciences. So what are the topics that is expected for you to know in the basic sciences, in infections, in poliomyelitis, neurological components of orthopedics, peripheral nerve injuries, metabolic bone disease. So what are the basic topics that are generally you are expected to know as a postgraduate student? So once you know these topics, you can always go back and refer to your books and prepare for these topics in more detail. Some people would have a habit of forming notes from different textbooks. That is also a very good idea. You can go ahead with that. But everyone has their own style of reading. What I would recommend is that read actively, think about what you are reading, and try to frame the questions in your mind while you are reading, so that you can retain what you are reading. Understand the questions. Pattern is becoming more focused and objective with time. You should also try and collect the previous year question banks. It is easily available for the DNB examination. So you would have for the commonly asked questions in the DNB examination in last few years. You can arrange these topics subject wise or chapter wise. And then once you are reading that chapter, you can emphasize on those particular topics, so that again, you have a place to start. You have a place where you can focus your mind, and you can assimilate those topics and retain those topics better. How to write in the exam. You should always use points, numbers, and paragraphs to highlight your thinking process. Avoid using long paragraphs without any breaks, because it gives a very monotonous thing to the examiner. It is not possible for the examiner to reach each and every word that would have written in these long paragraphs. Use your figures and flowcharts as much as you can. Avoid unnecessary highlighting or colors in your text. Avoid any repetitions of the ideas in your text. It gives a very bad impression about the person given the exam. And avoid unnecessary details that have not been asked. Irrelevant things just to add on to the text should not be done in the examination. Again, it gives a very wrong impression about the candidate. Clinical examination during practical exams needs practice. It cannot be attained through the theory or reading about the clinical examination alone. If you have read the clinical examination and not performed it by yourself, your examiner will be able to make out very quickly that you lack practical skills in performing those examinations. Present as many cases as you can. Make a methodological approach for the presentation. So you should always start with, for example, once you examining a patient, again follow a set. For example, the most common pattern that we say is inspection, palpation, range of movement, and special tests and measurements that would we say in orthopedics. So whatever sequence you are following, make a methodological approach for presenting your cases. and present as many cases as you can, so that the presentation is more like your spinal level. Be crisp and clear while you are presenting. Cover all common cases and long cases during your practice and your classes during your training. Understand answers rather than remembering them, because most of the time your examiner will be able to know that how confidently you have placed your answer and whether you know the background of that particular answer or not. Read important articles. So read important text from various books and even articles regarding this topic, which are commonly asked as long or short notes in the cases in the examination. Again, attending PG teaching courses where the examination parts are discussed in details and expectations from the candidates regarding each case is also discussed in details, is also a very good add on to your clinical knowledge. So once you're reading about the history and examination findings as a group or as a group or even as a single person, you can also try and develop the templates of the things that are need to covered in the clinical and in the history taking and the physical examination parts of these cases. So once you have these templates ready, you can practice it on the patient so that you know that what things are important in particular disease entity and what questions should be asked for in a particular condition of the joint. For example, what conditions, what all things need to be asked in a case of a tuberculosis of the hip, or what special questions needs to be asked in case of a tuberculosis of the spine. What are important tests which are not to be missed in these cases of in these particular cases. And so once you have a template of the questions during your classes and your clinical examination practice sessions, it will make things very easy for you once you are attending the once you are doing it at the time of your final exam. Don't forget that there are a lot of online sources available to you now. A lot of PG course lectures are uploaded on internet, on YouTube, on Ortho TV, which you can easily access. Lectures by various experts on various topics, very relevant to the MS exams, are also available, and you should try and go through them as much as you can. Familiarize yourself with PubMed. Of course, we would expect you to be familiar with this while you're doing your thesis, but again, it will give you more information about any particular thing that you would be searching for your examination. So instead of searching the Google, it would be better to search the PubMed for your clinical queries and explore the relevant good quality articles. Good quality articles would mean systematic reviews or reviews. Also try to understand the good narrative reviews from good journals of good standings. The one thing which I think is relevant to cover here is also affective domain, which is given more and more importance in present times. Even the present curriculum in most of the subject gives a lot of emphasis on affective domain. Various patterns once where we are shifting to OSCE's part of the examination, and even if it is not OSCE, even in long and the short cases, while the examiners are now seeing you examining the cases, they are giving more and more importance on the affective domain as well, which means that unless, although you may have knowledge and skill, but are you able to use your knowledge and skill for correct examination and delivery of the care to the patient or not? And to have these qualities, certain things are important. For example, the person should be a good communicator. Both listening and talking skills should be appropriate. You should know how to tackle the emotional issues of breaking bad news situation to the patient, how you're talking to the patient, what is your body language, how are you making the patient feel, whether you're making him feel comfortable or uncomfortable. Have you been able to build the rapport with the patient or not? Because unless you have built up trust and a rapport with the patient, you may not be able to gather enough history from the patient. You may not have the cooperation of the patient for examination also. Try to maintain the confidentiality of the patient, both during your history taking, clinical examination, and also during your documentation and records. How you are dealing with the relatives of the patients, how you're talking to them, how you are counseling them, whether you are a good member of a team work or not, and have been following standard ethical practices during management of the patient or not. Time and stress management are an important issue for education and training. During education and training of the postgraduates, time management is important. Time is limited and you have to cover a lot. You have lots of clinical duties as well, and between the duties from your emergencies to OTs to OPDs, you have to also gather time for your reading. Make a list, drop a schedule which is flexible yet realistic. Plan and execute. Do not procrastinate. You will never get the day which is completely set aside for study. You will never get a perfect day where you would be absolutely fresh for the study. Make study a part of your schedule. Incorporate your reading in your daily schedule and stay focused on what you have to read and what you are going to read. Managing the exam stress is important. Making study a priority. If you most of the time the stress arises because you would start realizing that a lot is pending and the time is short. So it's important to understand this right from the beginning so that you do not land up in a difficult situation by the at the fag end of your residency program. Needs time investment from your end. Minimize your distractions. At the same time, don't ignore your health and diet. Build up your CV, as Professor Maini rightly said. Be a part of your conferences, quiz, poster presentations, submit articles in the journal, submit your thesis work, attend relevant conferences in the courses to both to gain knowledge and also to build up your CV. So to conclude, reading starts right in the infancy of your residency. Give your reading a purpose. Understand your structure of the exam. Focus on case presentation. And do not forget that patient is your best teacher. Thank you.
Thank you. And thank you, Dr. Tarun Goyal sir, for such a vast topic in simple way. You have spoken a lot about to learn for all the PGs. And from the PG side, I want to know you, sir, in nutshell, there are 3 years, first year, second year, third year. Then please give some clues ki how to start in first year and what to read. Just 1 or 2 books, sir, please, because many of the books are there. We got in puzzle what to do, how to read. The seniors are also busy. The teachers are also busy. In first year, second year, third year, just 1 or 2 books, sir, we want to know so that our PG can follow that.
So we can divide the type of books that we would need. We would need a book for clinical examination, basic clinical examination. And to start with, you can go ahead with any book like Pandey, or even your S. Das would have an orthopedic part. And then you even have a MACRE, which gives you a basic orthopedic examination. So either one of these should be enough. Then you should know about basics of plastering, basics of splintage and braces. And again, the Stewart is the best book to read regarding that. Then third comes, for example, if you're posted in emergency and trauma during your first 1 year of residency, you would not have enough time to go back and read your Rockwood and Greens, which is a very elaborative book. You can read the trauma part from your either your Millers or your Appleys or even your MACRE would have a sufficient trauma part. Initial part, I would recommend that Miller or your Apple would be a good basic book to read. And at the same time, I would suggest that you the freshers in orthopedics should not try to read the book cover to cover. They should try to read the book topic wise. So you have seen a particular case, you go back and read about that particular case. You have seen a fractured clavicle today, go back and read about fractured clavicle. So like what are the different types of clavicle fractures, which clavicle fractures you think need surgery? If that patient was managed surgically in your unit, why do you think it was managed surgically? Could you find that explanation in your textbook or not? So that will help you to retain the things in for a longer time, even after reading.
Case to case is really helpful, and we are following your book also, sir. Case to case book that we are following. And sir, one thing more. What about the advanced orthopedics, sir? advanced orthopedics paper, because we have the DNB PGs and
The recent advances is the fourth paper in orthopedics. Generally, it focuses on more the things which have come in orthopedics in last 1 or 2 decades, and like it covers topics like orthobiologics and stem cells and tribology,
yes,
modern prostheses. These are the things which are generally covered, and I would say that most of the standard textbooks will not be sufficient to read these topics. You would have to, be aware of these topics and read them from good review articles. Again, there'll not be one source to read these all topics. Best would be to identify which topics can come as a recent advances and search for these topics in recent advances. For example, in our time, like FAI, femoral acetabular impingement, was a new term that had come, and I remember that it was hardly given in any textbooks, but there were good articles which are available on this. So if a new surgical approach has been devised or a new surgical procedure has been discussed, that can also be a part of the recent advances paper. So recent advances paper, for this, I think students will need some guidance from their mentors and teachers, and they would at least need topics which can come as recent advances. Sometimes they would also get to know these topics in various courses and conferences, but most of the topics on recent advances will be read through good review articles from good journals.
Thank you, sir. And sir, do you suggest for the conceptual orthopedics app to the DNBs? There are more than 100 videos, and many of the senior doctors are involved to give the training via that app. Do you want to suggest?
Definitely, they can have an app. For example, I definitely suggested that there are lots and lots of PG teaching lectures available on Ortho TV and also on YouTube as well. So although, this should be supervised, because they should not get any wrong concepts from or concepts which are not, universally acceptable.
Yes.
Sometimes there can be things which they would have heard in a lecture, but may not be acceptable as an answer in your postgraduate examination. So these things have to be supervised, and either the postgraduates, once they see it, they should clarify it with the seniors whether this is appropriate as a postgraduate answer or not.
And sir,
what app is also I think the app is good as well.
Okay, sir. Thank you. And one more last question, I hope so, sir. How to clear the OSCE? This is the last 1 or 2 years the OSCE is going on, and we have much not more experience of OSCE. Sir, any ideas?
Yeah. In my previous institution, I was in AIIMS before, and 50% of the marking we had kept for OSCE only. So postgraduates for last 3 years, they were regularly appearing for the OSCE examination during their pre-prof as well as professional examination. And the OSCE has a set pattern of questions. For example, if you have a child, for example, with a genu varum as a short case, and you are seeing that patient as an OSCE examination, then understand that OSCE covers all the components. It covers both the affective domain, that how did you approach the patient, did you identify the patient or not, and did you explain what you are doing to the patient or not, and then it will also have how did you start examining the patient, did you follow a logical sequence or not, did you cover all the ticks. So it will have about 10 to 15 ticks per question. So it becomes very, very objective, and it can be very high scoring as well, but at the same time, it can be very low scoring also, because you have to cover all those points during examination. And I would suggest that for the common OSCE questions, the students should develop their own template, that if this particular case is going to come as an OSCE examination, I have to definitely perform these tests and in this order, and it will need practice.
Okay. Thank you very much, sir. I hope our PGs got maximum answer from your side. And I would like to call Dr. Manish Ras to continue our next session. Thank you, Dr. Dal.
Thank you, Dr. Biren. Now we will move to the third session of this webinar, and our third speaker for this webinar is Professor Anil K. Bhat, sir. He is presently working as professor and head of the Department of Hand Surgery, Kasturba Medical College, Manipal. He had 86 international and national publications to his credits. He is author of 1 book and co-author in 2 textbooks. He had more than 400 guest lectures, 31 academic awards, 6 PhD theses, and 6 fellowship to his credit. His special interests are in hand surgery and wrist disorders. His hand surgery fellowships are in UK, Singapore, and Hong Kong. He is chief coordinator of HAST, which is Center for Congenital Hand Difference and 3D Printing Center at Mahe, Manipal. He is also the clinical editor to American Society for Surgery of the Hand and editorial board member for Journal of Hand Surgery, Asia Pacific Volume. He is also the chief editor of Journal of Karnataka Orthopedic Association. The topic on which he is going to speak today is stepwise approach to thesis from initiation to completion. Thank you for joining us, sir. It is our honor and privilege to have you here, sir. The stage is now yours, sir.
Thank you, Dr. Manish, for this invitation. Am I audible?
Yes, sir, you are fully audible.
Yeah. Thank you, Manish, your team, and the Jharkhand Orthopedic Association for this invitation and opportunity. And I've been training postgraduates in the last 20 years, and one of the most dreaded topics, or rather dreaded part of the post-graduation is the thesis itself. And this is the topic given for me for today's discussion. So let me start from the beginning. Let me start from the end. If you look at this picture, it is basically the culmination of your entire thesis process. And every postgraduate would wait for this particular day when they want to get the signature done from their thesis or from their heads of the department. And, most of the PGs would then post them on the Facebook or Instagram and then be very proud of it. And that's what most of the time the end happens. But a lot of times the end also happens like this, that once the thesis is done, it goes into the bookshelves of the department or library, or it just stops at that point. And that is the sad part of it. But then a lot of times you need to also look at things where it can be a very good kind of an opportunity. And this is my own postgraduate, just passed out 2 years back, and it ended up in this particular publication in a very good journal, a Q1 journal of this particular study which we did on dequerent stenosynovitis. So as a guide, as a teacher, I would be very happy if every of these theses ends up in this kind of a kind of an end, which is basically a publication. That's what we would want most of us, our students, to have it. So the question now basically comes is, why do you need a thesis? And I always tell the postgraduates that you need to be selfish during your postgraduate exam, postgraduation itself, the course itself, because why do you need a thesis? It's basically because of your requisition to pass your exams. So be selfish in that you have to complete your thesis and make sure that you do it in the right way without any glitches. So if, as Dr. Tarun was talking about, please go to this National Medical Commission's website, go to your PG curricula, and as you scroll down here through this link here, you would see Orthopeadics here. I'm sure even DNB website has this. So please go through the entire syllabus and see what is expected from you. And if you come to the thesis part of it, it's very, very clearly written in the PG Medical Education Regulations 2000. A new draft has come just now. There could be some changes which is coming up, but then as of now, this is what is valid, and very clearly written that the thesis shall be submitted at least 6 months before the theory and clinical or practical exam. And postgraduates shall be allowed to appear for the theory and practical exams only after the acceptance of your thesis. So there will be, examiners, at least 3 examiners who will be examining your thesis, 1 internal and 2 externals. and the 2 externals have to accept your thesis for you to take up the exam. So this is the basic part of why you require a thesis. But otherwise, everything is not related to exams. So it's basically, we are trying to put you into what is research methodology, right? And then to know what is evidence-based medicine or latest advances, because you have to use this evidence-based medicine in your practice to provide safe patient services. At the end of the day, when I sit as an examiner, what my criteria to pass a particular candidate is how safe this person is when he goes into the society. And that is the sole criteria a lot of times when you answer a particular question for a treatment or when you do an examination. I personally would be looking at how safe this person is for the society. And when you have this background knowledge of the evidence-based medicine and you use that for your patient practices, I think that is the best way you can actually start practicing once you finish your exam. So now let's come to the beginning. So basically, the definitions, at least you should know that thesis as such is not the document itself which you produce. It's a statement or a theory that is put forward as a premise to be maintained or proved. But your dissertation is actually the document we finally produce, which involves personal research, which is written by a candidate for a university degree. And of course, that happens to the research, which is to study a subject in detail, especially in order to discover new information or reach a new understanding, which is already existing in the domain of the knowledge itself. So how do we start this entire process, right? And one of the things, most important thing is the feasibility of your research. This is a very, very important thing, whether you are feasible, that particular topic given by a guide is feasible to be done in the at least 2.5 years. Generally, it's compressed to 2 years because it takes almost 3 to 6 months for you to finalize a thesis topic, get all the relevant permissions. And then the last 6 months, before 6 months, you have to submit the thesis. And some definitely, most of the universities are very particular about this. But otherwise, if it is interesting or novel, and it definitely has to be ethical and relevant, then it becomes even more interesting for you to enjoyable rather to do the thesis itself. So for me, the most important thing would be the feasibility. How much time you have, what are the resources you have, and how much expertise you have, and is it really relevant for you to do that particular thesis? And this is where your guide is the most important person to check whether it's not your job as a postgraduate. It is completely the job of the guide to check the feasibility of a particular topic. We can be sometimes very ambitious and try to do a lot of things, but a lot of times it's not possible during a postgraduate that short period what you have. So feasibility is completely the domain or responsibility of the thesis guide, and he or she should make sure that all these are taken into consideration, because at the end of the day, most theses end up with one, in the conclusion that the sample size is small or inadequate. The follow-up was not adequate. So this is not a good thing to happen. So when a thesis guide gives the topic, they should be very, very responsible and to see whether our own students can finish that particular thesis in a very good way. The next part is, these are the things I want to tell you exactly the order of how it needs to be done. So moment you know that it is feasible, then we start searching for what is the research question, right? And there are certain criteria. The classic is a PICO criteria, which basically means what is your patient or population, or what is the problem basically, right? And then what is the intervention or exposure you're doing? And then what is the comparative group? Ideally, it should have a comparative group, but not always necessary. Or there could be some control group. And finally, obviously, you're looking at the outcomes. Most obviously, every thesis will look at an outcome. And you're also looking at the timeline, very, very important, whether it's a short-term study, a midterm, or a long-term study, right? So all these, this is the basic criteria we follow in most of these things. Just an example here, if you look at this particular title, these are all publications, but I'm just giving an example. So if you look here, the patient population, the patient is an adult population where they have minimally displaced scaphoid fractures. The intervention here is cast treatment versus surgical fixation. So there is already a comparative group, two groups here. One is a cast and one is surgical, which are the basic interventions. Outcomes is told in terms of what is this outcomes. It is actually described later in the article itself, but they're looking at functional and radiological outcomes. And what is the timeline? Because it's a randomized study, it has a particular fixed timeline here. But something like this, here again, you have the patient or population where patients with acute scaphoid fractures, what is the intervention? Percutaneous screw fixation here. It doesn't have a comparative group. It looks at the outcome, which is basically of what is happening, the radiological unions, and the timeline is also given. So every thesis research question might not have all the PICO criteria, but at least you should start, when you start writing your, or rather searching for your research question, you should have this criteria in mind so that you satisfy this. Right here again, you know, in the title, at least none of these are mentioned. So your thesis title, when you formulate the thesis title, and thesis title should not be formulated in the beginning, it actually comes up or develops later. But then you should make sure that the thesis title is very clear and reads all these things and tells somebody, a reader or an external examiner, or to all these points of the PICO criteria that in the visibly very nicely put up in the title itself. The second part is the type of study you will have to choose. Again, this is the domain of the guide, and he or she has to choose the type of study you would want. And as I said, we can be very ambitious to conduct a randomized study or a prospective study, but these require a lot of resources and time. So a lot of times we end up with having retrospective studies or case control studies in our thesis. But there are options, there are opportunities to do prospective studies, randomized studies, if we are smart enough to choose a very nice topic. So this is how the ladder of evidence also goes. So the highest obviously is RCTs and the lowest is the retrospective case series. And beyond that would be the meta-analysis and systematic reviews. So these are also research methodologies which the students should know. And probably, I think nowadays, some of the institutes have started using this also. So this is the way somebody would choose a type of study based on the hierarchy of the evidence itself. The moment the research topic is given to you, the feasibility is known, your job now starts, which is basically to search the literature and see what is already available. So we should not always think what we're doing is the first time. Somebody somewhere in the world has already done it or thought about it. So we should be sure that who has done what and what is the outcomes. And the basic problem, or rather basic issue with the researching the literature, is for you to find what is the research gap and what new you can give to the society and the patient care itself. So if you can find that gap, that is the best thing about your research. And if you come out with something new, it will be amazing. So when you start doing this, my suggestion is to document this. Every article you download, you put it in an Excel file, the name and what is the article about, and then the characteristics of these. So store all these articles in a nice different folders and name them. Start doing this right from the beginning rather at the end, where you start scrambling for where did you read what and from where you have taken particular point for discussion. So start doing this right from the beginning. So when you write up the thesis, it will become very useful of all these. So start putting all these. You have a lot of access to articles nowadays. So start storing them in different folders and give the proper titles to them. So when you search the literature, as I said, what is already available, what is not, what is lacking, that is your research gap. That is where you're trying to find something new. And what that new can be found is that will lead to your problem statement. Right? You have a research question in mind, you search the literature, you have identified the knowledge gap, and that gives you the problem statement, which is basically now is going towards the aim and methodologies. Review of literature, start with the textbook always. The moment the topic is given, go to the standard textbooks and read about it first, understand the topic first, or what your guide has given. Go back to at least 10 years of publication. Okay, but that's a minimum at least. But also include very big, major research work or scholarly articles of the past. It could be 30 years old, but then just pick up one major one of that particular subject and take it. And in this last 10 years article, there could be a lot of good articles which can act like a template for your research. And as Dr. Tarun was showing, be very, very familiar with these search engines. PubMed is one, but there's so many search engines. See how to use them. There are very nice tutorials or videos of how to use the PubMed. Go through them, and so that your yield of your articles will be much better. Okay. Always check with appropriate keywords, the mesh terms, what is it called, or Google Scholar, and in various databases and index journals. And once you get that, once you finalize, these are my articles, so write short summaries of these relevant articles and keep it ready. And this is what your research, the review of literature section will have later on. So write short summaries The abstract will always have the summaries, but when you read the article, you also write down short summaries of it and highlight and keep it. Now, based on this, as I said, once you identify the research gap, your aim and objectives will come in. And again, this is utmost responsibility of the guide. That aim and objective, the wordings are very, very important, and they have to give you that, and you have to sit with your guide and discuss and see what all can be possible. And that aim and objectives should be SMART, which means that it should be specific, it should be achievable, timely, measurable, and realistic. So this is what we are looking at when you look at the aims and objectives. You can't put in 5 or 6 objectives, and you can't really achieve them in the short span of time which you have. And finally, when we look at, when I get a thesis copy, I look at aims and objectives and I look at conclusion and see whether they match. And a lot of times they don't. In the conclusions, there'll be a lot of philosophical writing telling you can do this, you can do this. No. What, as an external examiner or anybody for that matter, is looking at, have you achieved your aim and objectives? So that is what your conclusion should match. So that is what you need to do. Just an example, clinical and radiological outcomes in patients with distal radial joint instability and arthritis. So this was what a topic I had given. So here the aim is very clear that it's clinical and radiological outcomes in DRUG instability and arthritis. Now, how I achieve the aim is through my objectives. So the objective is for this instability part, I would do to compare the stability of DRUG after cast immobilization versus transfixation while in acute DRUG instability after we fix the distal radius fracture fixations. That's what I'm looking at, right? So that will tell me it is going towards my aim. The second part is arthritis. So I've chosen the objective to compare the outcomes of Sauvé-Kappanji versus direct procedure. So the aim is now split up into 2 different objectives, and I'm trying to reach my aim through these 2 objectives. And the next part would be the methodology, where for these 2 objectives, I have to find different tools, different ways of doing how to get these. There could be scoring systems, so many things which come into picture later. Now, 2 important events should happen now. One, you have to meet this lady. No, your statistician is what you need to meet. All the statistician might not be, so good, but otherwise, basically, what you need to do is to meet a statistician. Very, very important person in your life when you're doing the thesis. Study design, sample size, power of the study, how accurately you have to do the methodology is. So please don't meet a statistician at the end of your thesis where you go with your results. No, please meet the statistician right from the beginning, because your methodology becomes very, very strong. So they would give you all these things, take appointments, and make sure that you meet the statistician to get all these details from them. The second, obviously, would be the ethical committee clearance, the ethical board, IRB, whatever you call, different names are there in different institutions. And they have to give the certificate for you that you can go ahead with this. Basically, they're trying to say that don't deviate from submitted methodology. You might have to do amendments if you do any changes required. You might have to submit a closure report by the end of your thesis. But whatever said and done, every institution requires ethical committee clearance for your thesis. Every journals nowadays ask for a certificate when you send it for publication. So this is very, very important. So I'm just taking you to the same sequence as how you're supposed to do the thesis. So these 2 events of meeting statistician, getting your methodology right, ethical clearance for your thesis is very, very important the moment you have formulated your aims and objectives and your protocol. Very, very important. Nowadays, a lot of ethical committee will also ask for clinical trials registry or CTRI clearance also. So you have to apply this. You can't recruit a patient unless you get clearance from CTRI. So very important that your recruitment of patients should start only after getting this clearance. And they're quite quick and very efficient. They would send the clearance as soon as possible. This is the website you need to go, Clinical Trials Registry of India, and you have to register your trial, especially if prospective studies. But some ethical committees also ask for retrospective studies also, just to be on the safer side. So this is again a very important event which you have to finish. The soul of your thesis is the materials and methodology. If you send it for publication, actually, every editor would look for how strong is your methodology. The same thing applies to your thesis also. The materials is where you're doing the studies, the study setting, the study design, the sample size, the sampling technique. These are all your materials. The inclusion, exclusion criteria, these are very, very important in terms of the methodology is where to follow the guidelines for each study design. You design a study pro forma. There are very, very standard guidelines for the type of studies you're doing. If you're doing an observational study, there is what's called a stroke criteria. If you're doing a randomized study or the concert criteria, systematic reviews, there's a Prisma charting, even case report for that matter, there are criteria. So please go through these. These are available in the standard websites. So please go through that and make sure that you actually meet all these criteria. Methodology, as I said, is to be very, very strong. Again, the PICO comes in where intervention, complete details has to be written, the surgical technique or radiological measurements or drugs, whatever study you have, it should be very, very clearly written up. And you should be thorough with, like if somebody is given a thesis on only radiological measurement, you should be master of it. You should know every measurement, how to do it. You have your PAC system, most of the places have that, and you should be very sure of that. Comparative group details like the controls, outcomes, all the scoring system questionnaires, it could be any kind of scoring systems, whether it's for knee or hip or wrist or wherever it is, you should be very aware of it. And the study methodology must be, what we need to look at is that your study methodology must be replicated easily. So that is how tomorrow if somebody else has to repeat your thesis, your methodology be so clear that they should be easy to replicate it very, very easily without any kind of ambiguity. Statistical analysis is what comes once you start recording your data. So again, your statistician comes in, what statistical test you will have to use, the software, what is the version of the SPSS, what are the variables you have, continuous or categorical kind of variables. And meanwhile, at this is the juncture where you start your study, and then when you need to meet your guide regularly. That this is where a lot of times as guides we find that my thesis candidates are go missing. This usually happens in the second year. You just don't meet your guides most of the times because you're busy with the other postings, and this is the time where the entire thesis goes down, right? So at least every month, try to meet your guide and ask advice, relate your problems, find out what can be done for that. This is the time again you submit your review of literature. Don't keep it till the end. This is the time, second year especially, you have time, and this is the time you have to submit your literature and start writing the introduction now. Introduction should not be written in the beginning. You should start writing it somewhere in the middle, where you actually understood your thesis topic, what you're doing, and then you start writing the introduction. And review the methodology with the statistician if there are any issues. A lot of times we ask you to do a pilot study so that we know the feasibility of the study. And if you have to change the methodology, this is the time you have to do the course correction. Very, very important. Okay. And the introduction is basically, it's like an inverted funnel. So you have the problem, you're addressing the broad context of it. And then what is the thing you are doing for that particular topic? So the thesis statement may come at the end. So because of this, my aim of the study would be this, right? So the introduction tells basically what is the broad context of the problem, any major studies which have been done earlier, and what have they found, what is the knowledge gap, and what are you doing? So this is a 3 or 4 paragraphs you have to write of introduction. Usually about a couple of pages is good enough, but it has to be very clear as to what your thesis is telling. Follow-up of patients, again, is where the things falter. Okay, use technology to the fullest. Now you have WhatsApp, you have so many things. Make sure you maintain the patient confidentiality and take care of those things. But you can use technology for your follow-ups, because nowadays patients don't come for follow-up a lot of times. Build personal rapport with your follow-up patients. Make sure the patients are comfortable for them to come to the hospital for follow-up, and make sure they get the priority if you want to finish your thesis properly. Finally, when you start writing the results, that is where the entire it becomes very difficult. So you'll have to go for, again, statistician help at this point of time, and put in all the descriptive statistics, inferential statistics in the beginning, and put the complicated statistics at the end of it. Align with your objectives. No detailed explanation is needed when you put these tables. Need of data interpretation is needed, but make sure your legends are very, very clear. Everything, when a reader reads a particular table, they should understand the entire table. Okay. So they should know what is US, what is NS, what is this ultrasound group, or what is this. So they should know. So the detailed legend has to be written under every table of this. And the discussion basically starts by presenting the answer to your objectives. So my thesis is the aim and objective was this. So we did this, and that is why this has come out now. And then you describe your results, how they are supported by other studies, or how your results will support this other studies here. Do you have any new findings, and how can you substantiate? You need to give a very reasonable kind of explanation, a scientific kind of explanation if you have found something new here. And always have a section of limitations of the study, whether these have affected the results, what you could not do. And most of the time I find that sample size is small, so that should not happen here. So but limitation of the study is accepting what you couldn't do, but then whether these have any major implications on the results have to be cleared up at this point. But in your discussion, don't again repeat your results, don't put a lot of numbers and data there. Okay. Conclusions, as I said initially, valid and supported by the data itself. Directly it answers the original question, aims and objectives. Nothing else. No other point should be written there. Okay. And not to extend beyond the scope of this, what your study was intended to. That's very, very important. Deadline of submission, I have told you, for at least for the NMC. Master chart should be there. Your bibliography should be as per the criteria. Plagiarism check is very, very important. Most universities tell less than 15%. And external valuation changes. If it goes to the external examiner, they might suggest something, and you might have to do the changes and resubmit it to the university. So these are the things which might happen after you submit the thesis itself. So you actually start with review of literature. Okay, go to aims and objectives, then materials, methods, and statistics. Then you do introduction. Okay, then comes all your results, analysis, discussions, limitations, conclusions, bibliography, master charts, figures, photos, tables, annexes, graphs, acknowledgements, all these things. So if you look at any standard lecture, they will say start from introduction, aims, and no. Actually, the work is totally different when you practically do this. You start from review, aims and objectives, then go to materials, methods, and then finally actually start your introduction. This is the way practically it is done in a day-to-day life. Now, a lot of times postgraduates do have their problems. You are the first time you're getting exposure to the research methodology. Access to resources, some universities have best of them, some might not, like even a statistician or online research engines. Inadequate documentation, especially of, if you go to MRD, case sheets, so many things. If you're doing a retrospective study, half the things might not be there. And patient follow-up is a problem. As I said, use the technology as much as possible. And you have a limited time, just 2 years, maybe 2.5 years maximum. So you'll be running against time for you to finish your thesis at this point. The role of the guide is very, very important. As I said initially, aims and objectives, the research question, feasibility is the responsibility of the guide. So they should be very, very proactive in this. Review of literature, they should give help for search engines where they can find the best of the articles. Statistician help, they have to facilitate this. In the university, if you have a standard way of doing it, it's fine. Otherwise, they might have to get external resources for the student. And during discussion and conclusion is where the time where they have to again supervise you, but otherwise the methodology, the follow-up and all is a responsibility of the postgraduate. Now, good thing about this is you can do these paper and poster presentations. A lot of these, this is my own student, best who could get the best research award, even in the state conference and even in our university. So these are things which give us happiness as a guide, as a teacher. Publications, as I showed you earlier, the research culture is what we are looking at to be inculcated in yourself. And you should be proud to contribute to your field at the end of this. So that's how the thesis journey starts and ends. And a lot of times, I do hope my own students find something very new, something very exciting, and something very nice for the field of orthopedics. Thank you so much.
Thank you, sir, for such an extensive and elaborate presentation. Sir, there are few questions in the chat box. There is a question from a JR3. He said he has a problem in achieving the target sample size. The reason being, especially in COVID era for last 2 years, as hospitals are converted into the COVID hospitals. So, sir, he want to know what can be done in these cases.
Okay. Many of the universities took a decision rather during the COVID times. And that is where, again, your statistician helps you to truncate your sample size, right? So they can help you with that. Even MAMC came out with, guidelines during COVID time that, how you can finish your thesis. with a limited sample size. So but this particular batch, I don't think they have that guidelines in terms of submitting, because we are out of COVID. So they might be very strict on that. Even paper presentation, poster presentation, last time it was waived off by NMC. This time they have to do that. So the most important person again here is a statistician who would alter your methodology and who would alter your sample size for you based on the type of study you have.
So similar type of question is asked by another JR who said for due to redeployment of orthopedic resident to COVID hospitals, leading to non-working on the thesis. Actually, sir, for COVID, there is some problem in thesis collection. Sir, you in your presentation said that in some part they have started giving the topic thesis of meta-analysis and systematic review. Can it is generalized in India?
Yes, so these are the times where you have to look at alternative methods of the research topics itself. And it's very well accepted as long as your university is ready to stand by you and your external examiners accept, a systematic review is good enough. I mean, absolutely, especially during the pandemic, I think even we had a lot of these systematic reviews given to our students and completely acceptable. It's just that the university has to put in the guidelines and they have to come out with a statement that these research methodologies will be acceptable. Then the external examiners will also accept it. So that should not be a problem at all, right? And it's not easy to do even a systematic. It takes time, but then you don't have patient follow-up and things like that in that. So it's completely acceptable as long as the university takes a decision, your board of studies documents it, and it is passed in the academic senate, absolutely no problem. But this should happen at the department level.
Sir, in these cases, particularly in COVID, the question has been asked whether this study can be continued with another PG student, that is thesis in continuity can happen with different postgraduate students?
Ideally, no, in the sense that you have to have a different aim and objectives. The patient pool can be same, but there should be a different aims and objectives. You can't do the same continuation of the study. That is not allowed even by the ethical committee, actually.
Okay, sir. Sir, there is another question. It's not a question, it's a recommendation. Actually, it is JR1 question who has asked that at the time of the admission, they have no prior exposure to the research. So they have the suggestion whether research methodology course can be added at the time of the PG initiation, sir.
If you look at the NMC guidelines, you have to conduct a research methodology. All PG students have to pass what is called the SWAYAM exam now, and they have to register, and within first year they have to pass. This is from the Government of India UGC itself. There is SWAYAM portal, and it's a mandatory requirement for all the postgraduates to pass this exam. And they teach the research methodology here. Apart from that, the universities have their own research methodology workshops for first year postgraduates. At least in our college, we have that regularly. So this is a requirement actually. And SWAYAM examination is a must nowadays. So there is, if you go to the NMC, there is a link to the SWAYAM portal, and you will have to register within first 3 months after you join. And you have to complete that exam, and you have to produce that certificate within 1 year, before your first year. So it's a mandatory exam actually now, which has come.
Thank you, sir. We will move now to the next session. And the last speaker for this webinar is Professor Anand Kishore Pal, sir. He is presently working as Professor SSKM Medical College, Kolkata. He has 43 international and national publications to his credit. He is author of book on an atlas of orthopedic radiology. He was selected as one of the inspiring orthopedician of India of the year 2019 by Economic Times. He had won A.A. Mehta Gold Medal in National Conference of IOA 2002. He had Johnson & Johnson Travel Fellowship of IOA in 2007. He had won S.N. Baxi Gold Medal Award for Best Publication in IGO 2012. He had Joy Patnakar Gold Medal for Best Presentation in Pediatric Session in IOCON 2013. He is external examiner to DNB board and various universities across India. He is the immediate past editor of Journal of West Bengal Orthopedic Association. Thank you, sir, for having with us. Today, he is going to talk on what is expected in practical examination from examiner's viewpoint. Anand Kishore Pal, sir.
Good evening, Dr. Manish.
Thank you, sir.
So for your kind word, I'm very much overwhelmed to see these extremely important topics we have chosen for the postgraduates. And I think they are very much benefited with this. So without wasting the time, I'm starting my talk, that is what is expected in the practical examination from the examinee. So this is very important now, as this webinar, this is a peculiar webinar, this is a very good webinar as I am on the journey. So I am passing from the first year as Dr. Lalit Maini, followed by this thesis, this how to make this curriculum, and next ultimately the thesis is already had been submitted. Now I'm being a student, like a student, I'm going to become the to appear in the examination, in the final examination. Now as a student, and now what I feel, so what we expect from the students in the final examination, that is the main theme of this evening. Now, practical examination, basically it is the examination of the cognitive as well as psychomotor plus the affective domain. So there are clinical class, there are several pattern of questions, but in most of the cases there are uniform distribution, like the clinical case presentation, where there is one long case and 3 short cases to be examined, and some cases in some centers along with the long case, there are surgical anatomy, and the operation is asked along with this. And after that, this clinical examination, there will be oral and viva voce. There are basically, most of the centers, they are considered as a 4 tables, like the specimen plus osteology is the first tables, followed by the radiology with flying oral, with specific emergency orthopedic problems are being asked. And then third is the orthotics, prosthetics, the basic research, methodology as is being discussed, followed by the recent advances and the thesis. What you have submitted in the thesis, some questions is asked about their aims and objectives, their conclusion, like that. And lastly, another 4th table is the instrumentation, the operation. So this is the basically the classical examination pattern, which is followed by the different universities and the colleges. But now being is as being the COVID, post-COVID era, there are some other procedures are also being is established, it is being followed, like the OSCE system. And then there's a case one in OSCE system, there is actually a maybe virtual case, or maybe 1 real case, or 2 virtual case, 1 real case, like that, followed by the oral and viva voce station, where there are 4 word round and 4 stations consisting of the same as in the oral and viva voce in the classical examination. Now the OSCE, just I'm going to touch to the OSCE. This is not the, we not get very much time. If we get time, we can discuss in elaborately. So in OSCE system for the students, we have to mind that time span. There's always a fixed time span. Suppose there are, we have to answer the 100 questions in at least 2 hours period, like that. So in each questions, in over the question that is written that we have to answer the questions within 4 minutes, like the 4 minutes or the 5 minutes, like that. So mind the time spent is extremely important. Next, we have to notice what is the marking it is given. It maximum number is allotted for each OSCE is either 6 or the 10, between 6 and 10. So and that is divided into two questions, that may be into 3 questions or 4 questions or 5 questions, like that. If there are 5 questions of 10, that may be most probably there are 5 into 2. That means each question is awarded for the mark 2 number. Next, we have to see, there will be some picture of the video. I will show how it is it will be shown to the students during the examination. So we have to observe peculiarly, we have to observe accurately the video and the pictures, and to analyze what is going to be shown. And lastly, you have to give the to the point answer. Now come to the virtual case. In virtual case, special norms is some information is already mentioned, some information is asked. Some information is already mentioned, is the background of the case, in a short history may be written over here. There may be some video of the gait may be there. The picture of any part showing the specific deformity on the sign and the specific name of the sign of the procedure may be asked. or there is some video of some test is being shown, and there are several questions being asked on this. And there will be, again, the time allotted and the number is already given there. We have to see, every student should have to see that, otherwise it may be a mistake, then the time will become flee away, and he or she will be unable to answer this. Now, information asked on this basis of the information is that we have to do the, suppose there are, these are the examples, like the probable diagnosis, differential diagnosis. Suppose there is a gate is given, so we have to ask for the identification of the gate with the explanations, whereas some clinical test is being shown, and then the ask question is the identification of the clinical test with the explanations. Some investigation is video is given, and the question is asked, what are the relevant investigations associated with this, and then the related management. Now, see, this is this is the example of a virtual case like this. A 38 years old male had sudden onset low backache following lifting of the heavy object from the floor for 5 days back. Now, these are the standard questions that may be given in the as a case scenario or in the OSCE session. So in the case scenario, suppose these are the case, these are the questions. Mention one relevant clinical complaints. Suppose see this is if you have to observe this picture. So this is the patient is complaining of severe acute onset low back pain during the lifting strain. So what should happen? That may be a acute prolapsed intervertebral disc. And what is the common complaint on this? Relevant clinical complaints may be there is a pain during walking, and there will be heaviness or pain that is relieved when he stops walking or lean forward. That is basically, it is known as the neurogenic claudication. So that is a relevant clinical complaint students should write this neurogenic claudication. Now, identify the inspectory finding in figure 1. So what is the figure 1 showing? So this is a little bit, maybe either scoliosis or a list. Now see the next figure, figure 2. See, on forward bending, it is this bending, this curvature, this coronal plane curvature of the spine is completely abolished. That means it is not a scoliosis, it is a list. So this we have to write it down. Identify the inspected finding. So it is a coronal plane deformity with convexity. It is a dorsal lumbar scoliosis with dorsal lumbar curvature, convexity towards the right. Most probably it is a list, and as it is evidenced by the complete correction on the figure 2. Now, clinical test is basically it is a flexion test. Now, mention the common differential diagnosis. So these are the commonly questions asked in this long case or in the OSCE system. So these are the key. It is given. Mention the common differential diagnosis. It may be it is a scoliosis. And what are the special tests? Let's give the Braggart's test. And what is the most important emergency out of it? That is a chorda-equina syndrome, compressing the nerve roots of the PIVD. Now, see, this is another case I can see here. This 18 years boy. See, this is 18 years boy with complaining of the low back pain and the painful left hip motions, especially in the early morning for last 3 years. So these are the questions may be asked. Identify the gate. See, what is the gate? You can see here. Basically, it is a Trendelenburg gate, as you can see here. The sound side sags, and the whole trunk is swaying on the side. So this is in this way the question comes. Now come to the real case, which is most important. In most of the real cases, then no information is mentioned, but maybe optional information. But the information asked, this is extremely important. Like this, you have to take the history, and you have to analyze the history to that is a cognitive domain. So analyze the history to categorize the disease. So broad categories. At the end of the history taking, the examiner may ask, what is the probable diagnosis? So in that case, we have a broad category of the disease, maybe traumatic disease, it may be infective disease, inflammatory disease, like that. Next, we have to see the clinical examination. And clinical examination, you may be asked to show some specific test, which is basically the psychomotor domain. And lastly, the summary in the long case. Again, it is a psychomotor domain. How will you summarize the case? So how concise the case so that we come to a diagnosis. Now, next is the provisional diagnosis, followed by the differential diagnosis. Again, it is a mixture of the cognitive as also the psychomotor domain. Now, lastly is the relevant investigation, and this management is a cognitive domain. And most important, how to make the RAFO and take the confidentiality of the patient, and how you counsel the patients if may be specially asked by the examiner, and that is basically the affective domain. So this in this way, so this is the standard questions. It is asked in every examinations, every case. It's a long case or it's a short case. So in the short case, basically the summary is not being asked. As short case, it is started with these different provisional diagnosis, differential diagnosis, different investigations. Some tests may be asked to be shown, and lastly the counseling and the management. So these are the standard questions asked in the long case. Now, how do you analyze the history? Now I'm going to some tips for them. So suppose there is a pain. Pain is the most common complaint in every case. So basically, how will you, at the end of the history, we can, how will you broadly categorize the disease? So these all types of pain, if we see, it may be divided into three types. It may be mechanical pain, it may be inflammatory pain, or it may be infective or neoplastic variety. In mechanicals, just only two questions. Even in a very busy OPD schedule, you can easily categorize. There is a what is the aggravating factor and what is the relieving factor. If the aggravating factor is the activity and the rest is the only relieving factor, is the pain, there is no pain at all if the patient is taking rest. Whether there is if the patient is complaining of pain when there is activity, it is basically it's a mechanical pain. Just opposite, when the patient is complaining of pain, when the patient is in the rest, that is at the end of the night, in the middle of the night, or at the beginning of the morning, so that when the patient is absolutely in the bed, patient is coming with severe pain and it goes away with the activity. So that is the inflammatory pain. It's basically it is associated with some morning stiffness, and that's basically the rest pain. Always remember, the rest pain relieved by the activity is basically is a feature of the inflammatory pain. Whereas an infective or neoplastic, where the cause is already present, always present. So always there is some activity that increases the pain, but there is no relieving factor unless it is that some medication is taken or some surgical procedure can be taken. So otherwise there will be no relieving factor. So this is a broad categories can be easily done by these simple questions. Now, how again, there is another example, how to analyze the history. And then acute limitation of the, suppose this is the case, as acute limitation of the motion of the hip after playing football in a 7-year-old child with or without fever. What are the possibilities? See, what are the positive history? What are the negative history? What are the positive history? You have to see whether there is a fever, like we say, suppose it is a low-grade fever or it's a high intermittent fever, that may be infection. Or there is no fever, but there is absolutely symptoms persist more than 2 to 3 weeks. So that may be progressive or not. It is very important. How do you know whether it is progressive or not? It may be deterioration of the symptoms. It may be gradual reduction of this activity of the daily living, or gradual reduction of this walking distance. These 3 points. So these 3 points, if it is present, that is progressive. Now we have to see whether these symptoms are progressive or not. If there is this symptoms is not progressive, it subsides within 2 to 3 weeks. It is a case of transient synovitis. But if the symptoms is persisted, but the painless limb, initially there may be pain for transient pain persists for 2 to 3 days, which pain subsides when patient is continued with the painless hip. Disease is persisted, progressive. Basically, it is a case of Perthes considering this scenario. Whereas in the same scenario, if there is a progressive painful limb, basically it is an infection with or without fever. Remember, fever may be absent even in presence of infection, like the tuberculosis. In 20% of the cases, there will be absolutely symptomless. So progressive painless limb may be in favor of infection. Now, we have to see there are some other negative history, like there is no significant trauma. We exclude the traumatic disease, pain on the other joints. So we have to exclude the inflammatory disease. Again, waxing and waning of symptoms, again, exclude that inflammatory disease. And the cardinal symptoms means there is some loss of appetite, sleep, bladder, bowel. These are significant loss of body weight. These are the cardinal symptoms. If the cardinal symptoms are positive, that is a very dangerous or sinister significance, like there is a systematic infection like the tuberculosis or the malignant disease. So this negative history must be taken at the end of the history for categorization of the disease. Now, the examination protocol of the orthopedic cases. Now I'm going to make the life of the my postgraduates very easier, because you have to very easy. This said there are figures, 7 figure and a 3 figure is a very magical figure in our life. So always we have to understand. So the examination of the orthopedic complaint should be divided into 7 broad heading, and each broad heading is divided into 3 subheadings. And we have to write in a long case. There are some questions in some examination. The answer book is given, and everything should be notified on your this answer sheet. So these are 7 broad heading, like the inspection, palpation, movement, measurement, special test, Next, the examination of the proximal joint and the distal joint. Lastly, the 3 points is clubbed with 1 point. There's a neurological examination, vascular examination, and the reticuloendothelial system. That means the lymph node examination. Now, what are the points to be mentioned? That's a must mention is the inspection. So inspection is started with the gait. This is the most important point. We have to examine the gait first. Because why gait first? Because after some examination, like the movement or the tenderness, when if the pain the status is increased, that is pain status is deteriorated. So in that case, even a painless limb may be converted into the painful limb. So always examine the gait first. Next, the 3 point is the attitude deformity, swelling and wasting, and the skin abnormalities. And if you consider all the points will cover by these 3 simple points. And remember, all these points should be examined in different positions, like the standing positions, supine positions, from the front, side, and back, like this, or the prone position. Next come again the palpation. Again, there are considered 3 points. So always all the broad heading is considered is have 3 subheadings. In the palpation, we started with the local temperature. Temperature is always to be the first point. Why is the first point? Because some movements, after some movements or some other palpatory methods or measurements, local temperature may be artificially improved, so increased. So that is a fallacious. So always examine the temperature with the first point is a palpation. Now come to the tenderness. So tenderness should be elicited over the bone, over the joint line, over the soft tissue, or maybe some spatial tenderness. And we have to always see the face. It is most important point. Lastly, the palpation of the bony swelling. If there is swelling, we have to palpate the swelling. If there is no swelling, we have to palpate the bone or the soft tissue in the joint is most important. And lastly, the palpation of the skin abnormality, like the ulcer and sinus, if it is there, we have to palpate whether it is fixed to the underlying structure, whether it is tender, whether it is the surface, everything. Now the movement, again, the movement of the 3 points. 3 points. So all broad heading has the 3 points, like we have to examine the normal side first, then come to the abnormal side. In the abnormal side, always start with the active movement, followed by the passive movement, followed we have to compare the other side. So always compare the normal side with the abnormal side at the end of your movement. So what are the points to be examined? Suppose the passive movements or the active movements, what are the points to be examined in each movement? See whether the movement starts from the neutral or the deformed position is most important. We have to measure the existing range of motion. Next, lastly, they ascertain the existing range, whether it is associated with pain or not. If it is terminally pain, that suggests the synovitis, but the whole arc is painful, that is the arthritis. Suppose we have to write. So this is the guide to write in your answer sheet. So this is a flexion of the hip joint. Suppose you have to write in this manner, make a simple chart in this manner. So on the right side is normal, left side is abnormal. Deformity is the right side is normal. So there is no deformity. Arc is 0 to 140 degree. There is no pain. Whereas in the left side, there is 15-degree deformity. Arc is 15 to 90 degree and is terminally painful. So what is the interpretation? So there is basically a synovitis. So again, see this scenario. This right side is abnormal, left side is normal, hip flexion, deformity. Right side is a 40 to 45 degree, arc is 45 to 60 degree. The whole arc is painful. So you have to write in this manner. It is easily to understand. This is a case of arthritis. Now, why it is arthritis? The patient maybe the examiner may ask in this question. Now, this is the answer. The patient, why it is arthritis? This is where pain increases with the motions, with the hip motions. That is why it is arthritis. Now, the 2 types of movement pattern of restriction, like all movements symmetrically painful and restricted. That is a global involvement that can be seen in this sort of scenario. So you can this is the normal side, this is the abnormal side, and you can see this is the significant. This is generalized osteopenia with reduction of the joint space. Most probably it is a case of infective arthritis. Commonly it is a tuberculosis. So we have to argue in this manner. So if it is a tuberculosis, so there will be global restriction. That is, all movements will be symmetrically painful and restricted. Similarly, in this case, you can see here, there is a concentrated reduction of the joint space. There is osteophyte. So there are some subchondral cyst. So the secondary degenerative arthritis following the inflammatory disorders. So basically that will lead to global restriction. Whereas in this case, you can see here, you can easily understand if the head is flattened, but see there is no signs of degeneration. So if there is a mechanical detachment, so then in that case, some movements will be less restricted Some will be grossly restricted or absent. So in that case, so what are the movements to be grossly restricted? Especially the abduction and the internal rotation will be grossly restricted, whereas in the flexion will be almost full. So this is basically, it is a sectorial involvement that indicates the mechanical derangement. This is not, that is not a global, that is infective or inflammatory restriction. Now the measurement, how will you write the measurement? There are three items. It may be apparent length measurement, it may be true length, or the gut measurement. And you have to write in this manner. So this is a simple chart. This is the right side is normal, left side is the abnormal. We have to write in the what is the apparent length and is the true length like this. And then at the end of that, we have to write it down. The conclusion that maybe the apparent length is 2 centimeter length is 2 centimeter more than the affected site like this. On the special test, that depends on the case to case. It should be specific to specific joints, and for the hip joints, every case it should be different, and we have to write it down accordingly. Now, what are the points to be examined in the proximal and the distal joints? At least 3 cardinal features should be examined for the proximal and distal joints. Now, what is that? These are in deformity, whether there is any tenderness like the bony or soft tissue or the joint line tenderness, and at least what are the movements which is seen. Suppose it's the hip joint, always examine the spine as also the knee joint, and also the sacroiliac and the spine is most important. We have to examine for the hip joints. Now for the last point, where the 3 points is already clubbed, that is the neurological, vascular, and the reticuloendothelial lymph node system. And for the examination, again, don't forget to see the gait, which should be examined at the first point as an inspectory finding. For the heavy examination, always ask for the parectal, though it is not required. So you have to ask for this, the examiner will understand, the student will know what is the importance of that. And for the long cases, examine the other system, it is extremely important. Now, it is extremely important is how will you write the summary of the case. Now, this is the model summary of the case in a Kerry spine. So how will you write it down? See, it is written like this. The 18 years old female presented with a gradual onset progressive dull aching pain in the middle of her back or the lower thoracic region for the past 5 months, followed by sequential incidents of weakness of both the lower limb simultaneously from distal to proximal, difficulty in wearing shoes, and then the walking with other sleeper. See, this that indicates that there is sequential involvement from proximal to distal, distal to proximal, and that is happening for the last 3 months. And incontinence with the urine and the irregular bowel habit for the last 3 weeks when she was become totally bedridden. So that indicates it's a classical history where there is a brunt is coming from the front that involves the motor involvement. First, as the brunt is coming from the front, as the distal tracts for the distal part of the body is on the outer side. So that involves first, followed by the upper part. So that is how it is involvement from the distal to proximal wards. So everything fits with the involvement from front to back in respect to the spinal cord, and that is a classical presentation of the Kerry spine. Now again, it is written, see the systemic features. He is anorexic, and there is a significant loss of the body weight. This is significant for the, I'm already told, if it is the cardinal features are there, they will suggest there is sinister significance, there is systemic disease like the Kerry spine or the malignancy. Then there's the sequential involvement coming from the motor fast, followed by the bladder bowel. That indicates that it is a extramedullary involvement. The sequential involvement that is suggesting it's a Kerry spine. And there was no history. We have to write it down in the summary. There's no history of trauma, fever, chest pain, cough, and patient is taking a particular drug. If it is there, we have to mention, and for the last 1.5 months without improvement. Now, how to summarize the examination? On examination, there is a gross wasting of both the lower limb muscles, tenderness over the D6 to D9 vertebrae, spastic paraplegia in extension with a sensory level from D11, motor level is a D10 onwards, extensor plantar reflex, ankle and the knee jerks are exaggerated with ankle and patellocronus, and there is a presence of the joint position vibration sense. As there is a position of joint sense are intact, that indicates it is an incomplete involvement. So how to give the provisional diagnosis? This is what is the ideal provisional diagnosis in such a case. This is a case of the compressive myelopathy, as it is evidenced by sequential involvement from front to back. As I explained, it is an infective origin, probably due to tuberculosis is suggested by the systemic features, What is the D6 to D9 vertebral level? Why? Because it is suggested by the tenderness. It is a D10 spinal cord level. How it is ascertained? Because of the upper sensory level and the upper the motor level, as evidenced by there's some beaver sign or the abdominal muscle examination, resulting in incomplete spastic paraplegia. How it paraplegia in extension? How do you know it is an incomplete paraplegia? Because there are position vibration senses intact, and there's even in spite of the blood level involvement. And under the treatment of the anticoagulant drug for 1.5 months without symptoms and signs of recovery in 18 years female, they will complete the diagnosis. Now, this is another case, as you can see here. This is the example. So this 80 years old girl complaining of the recurrent fall on the grounds for the last 5 years following some injection in the left thigh. Take for the diarrhea, which is taken for the diarrhea for early childhood. These are the questions it is asked. It may be a simulating case, or it may be a OSCE system. So you have to ask for the complete diagnosis. We have to mention the 2 pathologies resulting this. We have to prescribe the 2 investigations, and we have to mention the 2 standard surgical methods. So this is again real case. So it is asked how to exclude the hip flexion deformity. So it's happening. So there may be flexion deformity of both the hip and the knee. How to ascertain which one is the actual cause? Now see, this is a bedside test. So if you do that, see the hip flexion is completely gone. So that is because of the knee problem. Now, how to assess the next question? How to assess the flexion deformity in bilateral hip affection, and we have to answer this. So this is the way you have to answer. Now, this is the ward round. Suppose there are 4 stations in the ward round, like this station, like skeletal traction, post-operative patient with the drain, chest drain, airway, and the oxygen mask, and the long leg groin to plaster. Now, how will you approach this? We have to identify the system first. We always start with the patient as a whole. Whether the patient is patient may be is a very generalized general condition, is very weak. Patient is taking oxygen like that. So we have to, what are the condition of the patient? So whether the patient is breathlessness or anything else. So we have to examine from the patient first. Next, the examination of the limb, followed by the management system. Next, if the systems, all the systems are the working well or not, you have to see. If not, you have to spot the problem and you have to suggest the correction. Lastly, what are the corrective measures to be taken? And patient, again, you have to ask what are the possible complications and the preventive measures in this case. Suppose this is the case. It is a 25 years old treated by this method due to the closed floating knee injury with altered sensorium for the last 7 days. Now, what are the questions? See, we may be asked, what are the exact site of insertion of the traction pin? Which soft tissue complication will you expect from the improper padding of the spine? Now, name any special knot required to tie the rope with the bowler stirrup. See the knot is given. Basically, you have to answer that may be the sailor's knot. If the traction is working properly, yes or no. If it is yes or no, you have to explain it. Now, which iatrogenic complication of the foot will be expected from the faulty insertion of the calcaneum traction pin? So you can see here, this is increased arch of the foot. That may be the injury of the local nerve, medial calcaneal nerve, or there may be some possibility of the injury of the common peroneal nerve, which is by the abnormal rotation of the limb against the bar of this splint. Now, how to dress the skeletal traction pin track side? See, this skin, how will you dress it? There are 2 types of dressing. It may be closed dressing, it may be open dressing. The open dressing is the ideal one. Now, see, these are the keys. The same thing may be asked as a ward round, is a virtual key ward round, everything. Now, this is another case. I'm not going to detail. These are the some examples of this. So the ward round, we have to check the plaster and the limb. So whether it is a transverse seat upper extent, whether it is a transverse and oblique Y, lower extent is a palmar. So in the palmar side, why up to the proximal palmar crease? Why not up to the distal palmar crease? These are the questions asked in this manner. Now the Viva voice station, it's like the radiograph. Now, what are the points to be followed up in the radiograph? We have to identify the radiograph. We have to describe the different details of the radiograph. We have to diagnose. You may be asked for the differential diagnosis. Next, the investigation for the confirmation, and lastly, the management. Now, how to prepare for this? Now, we have to describe symmetrically. There's ABCD. What is ABCD of reading how to read the radiograph? I'll show you. This is the basics. After completion of the basics, we have to go by the lines and the signs, and we have to do this special diagnosis. Now, what are the basics? What is the ABCD? We have to see whether the plane is adequate whether plane is a standard plane, standard view or not. And so you have to see the alignment and what are the rule of two. I'll show there are two views, two sides, two occasions, sometimes the two sides. So especially in the child for comparison of this epiphyseal plate. So these are rule of two. Now the bones, if the bones, we have to go from the outside to inwards. We have these extra cortical, there is soft tissue shadow, then is the cortex, then the medulla, and you have to see the joints. Next, you have the calcification. There are 4 densities in the bones. So it may be white, it may be intense white, it may be gray, or it may be black. So there are 4 densities that may be suggestive of specific implications. And you have to then next, lastly, you have to see what is the defect, what is the density, again, this 4 density, and what is the date, whether this X-ray is a fresh X-ray or the old X-ray. For the patient, we have to see what is the age, which is a mature patient or the immature patient, as a background clinical, if it is possible. And next is the side, maybe right or left. As you can see here, these are the rule of 2. I've already told. Rule 2, 3, 4, we have to mention. Rule of 3 means 2 views, 2 joints, 2 sides, of 2 occasions, 2 sides, and some special views. And 3 points means we have to see the patient's scenario, soft tissue scenario, and the bone or joint scenario. 4 density, black maybe depending on the ear. It may be gray, soft tissue, white is the bone, metal is the intense white. So this is suppose how to describe this radiograph, this sort of radiograph given in your examination. So this is the standard answer should be the anteroposterior radiograph of the immature knee. See this epiphyseal scar, the immature knee with the eccentric homogeneously lytic lesion in a distal femoral metaphysis with cortical break, with narrow zone of transition. You can see here with suspected soft tissue mass. So most probably it is a benign aggressive lesion. Sometimes, so the same thing, it may be a malignant tumor in a mature bone. So now the next one is there are several questions asked like this: difference between the angulation and the tilt, how to measure those. So these are the points may be asked in the radiological. So I'm not going to detail. There are several lines. Because yes, some lines may be drawn. What are these lines are called, and some spot diagnosis. So this is normal radiograph of a hand, and is it the hand? But see the wrist. We have to check the wrist. See, there's a cupping, fraying, everything. There's an increased fascial depth, as also small epiphyseal. So this is a case of ricket. And see that this is this abnormal radiograph of the hand. See this, the length of the index, middle, and the ring finger almost the same. So this is a trident hand, which is close, which is a very common in achondroplasia. Now, what is it may be asked? What is named the name of the operation? This is Subkapanji technique. It may be asked in this, and what is the technique? What are the details? What are the indications? May be asked in this manner. Now, the instruments and implants. So, what are the concepts? Once there may be instrument or the implants. The implants we have to give the nomenclature. We have to identify the parts of the utility. We have to specific use and steps in operation, and the last technique. And the instrumentation with the nomenclature, parts with the utility, how to hold it. Now, what is the general use? Suppose it's the periosteum elevator. Always remember this. This is the ABCO. This is always used in this manner. So it is A for the amputation, B for the bone grafting, C for the chronic osteomyelitis, that means sequestectomy and saucerization, and O for the osteotomy. So in this is a general use of all the general instruments. Now there are some special use may be asked, and then lastly the sterilization. So these are the common questions asked in the instruments and implants, and sometimes it is modification of the instruments may be asked. So this is the last one. We prepare for that. Now orthotics, prosthetics. Now the prosthetics and orthotics may be asked like the nomenclature. You have to ask the nomenclature. Next, the parts with the function, how to use and where, like which strap of the pelvic harness is tied first. That is basically is the chest strap. So always these are the questions may be asked. Now what are the indication and the contraindication? Lastly, the limitation and the complication. Now with the prosthetics, again, the nomenclature, parts with the function, the indication, contraindication, complication, the guidelines and advice for use. So advice for use is most important. Now just going to the clue, this is very, very gentle, very, very useful clue. That is how to classify the orthosis. Always remember the orthosis which encompasses the joint determines its orthosis. The orthosis which encompasses the foot, this is a foot orthosis. So the foot, if it encompasses the ankle and foot, this is ankle foot orthosis. So in that way, so everybody we are wearing this, every day we are wearing this foot orthosis, that is the shoe or the boot. Now, how will you differentiate the shoe and boot? This is the question may be asked. Similarly, it may be the finger orthosis, it may be hand orthosis, maybe wrist hand orthosis like this. Similarly, in the spine, it may be cervical orthosis, cervicothoracic orthosis, sacral orthosis like this. So this is a very useful and universal classification we have to follow. And you need not remember the name of the specific orthosis. It may be, sometimes it is asked in the examination. Now the indications, there are basically 3 indications. It can holds good in every situation, like weakness, like UMN or element weakness, loss of the structural integrity, and the deformity. So it may be flexible and the dynamic. So suppose it's a wrist drop. So it's in any orthosis like this, the static cock-up splint. That static cock splint can be used for this loss of structural integrity, deformity, like the wrist drop, even in the UMN lesion to prevent the contraction. So these are the indicators. That is how it can be used. So suppose this is the cases, you can be asked, what is the name? What is this is the collar. This is the 4-poster collar you can see here. So this is this is the public harness. Which strap should be applied fast? That will be asked in the examination. Now the research, again, the research, we have to ask for what are the types of the research, what are the variables, sampling technique, formulation of the basic research question, level of the evidence, and the indices of the assessment of the journal, which is elaborately discussed in the previous author. Now, another important recent advances. So we have asked of the cartilage defect, like the robotics, 3D printing, new tribology, bone graft substitute, there is stem cell, microsurgical technique, modular facilities. Now the operative, in operative, we have to have the pre-operative checklist. We have to which anesthesia may be used, position of the patient and the limb, what is the approach, what is the incision, what is the muscle interval, that is important nerve and vessels is coming in your interval, what is a specific technique, and what is the post-operative care. And these are the special questions. What are the plannings before operation? How to prescribe the implants? What are the surgical anatomy? What is a specific danger and complication particular to a specific operation? The osteology, that may be long and short bone, it may be articulated hand. In long and short bone may be asked, you have to hold in anatomical position, parts with attachment of the muscles, vessels and nerves comes to close to, suppose the humerus is given, what are the nerves comes to the humerus may be asked. Anatomical peculiarity of tibial plateau, or the medial tibial plateau and the lateral tibial plateau may be asked. What are the area of implant insertion or the placement, suppose the insertion of the nail in the proximal femur, different types of nail and the different sites of insertion may be asked. In articulate hand, parts of the attachment, what are the arches and the lines related with the attachment, articulation, the alignment, the anatomical position may be asked. Now specimen, it is most important specimen. We have to identify the parent bone, is most important, identify the lesion, and it may be the nature, it may be malignant lesion, it may be location, you have to epiphyseal, metaphyseal, and the diaphyseal, type of the sequestrum, what is it like if you type of the sequestrum is given, what is the cause, what is the fate, what is the management, it may be asked. Sometimes the microscopic feature is given, suppose a giant cell is given, so you have to identify which type of giant cell, which cell it is shown, is being shown, and you have to explain it. You have to next, what is the cause, what is the indication, and how to manage this. So this is the way. So this is sequestrum. These are questions is asked: identification, types, fate, diagnosis, management. Now the spines. What are the preservative? It must be asked. How to identify which spine it is? What is the pathology? And what is the how do we explain this? So this is the questions for the tumor, like what is the preservative? What is the structural identification? Anatomy. So suppose this sort of bone is given, how to identify the long bone? See the cross section. It may be triangular cross section, it may be rounded cross section, maybe a particular bone. Suppose in the femur, say always it may be in the middle part it is a triangular, in the lower part it is a rounded. Whereas in see the lower part is confounding the condyles of the femur, so it is a femur. Now see the pathology. You have to start from outside inwards or from center to outside. So this abnormal, so whether is abnormal soft tissue shadow there is no abnormal soft tissue shadow, cortex is thinned out, and so you have to whether it is thinned or broken. It may be central or expansile. The zone of transition, see the zone of transition, it is abruptly it is ended. So it is a very narrow zone of transition. And see this is epiphyseal metaphyseal region. In a mature, so there is no physis is seen. So most probably it is a case of, it is a, and see that inside it, see it will be whitish area or a blackish area. Whitish area is suggestive of the fresh area. Blackish area is suggestive of the necrosis or the hemorrhage. So basically, it is a fleshy tumor, expansile in the mature bone, in the femur, lower end of femur. Most probably diagnosis is a giant cell tumor. So what are the tips of practical examination? We have to keep your mental pause and frame to present with the safety and the care. Wishing to examiner is extremely important at the beginning and the end. The attitude and the candidate is extremely important. We have to dress and attire should be clean and smart. We have to control over the senses by practice. And we have to expose the marking, proper lighting, daylight, and the female attendant is required. Now, exam kit bag. What should be the exam kit bag? These are the exam kit bag to keep it in your side. Now, these are the optional. This is very important. Sometimes very important for the patient also. So if you if you give this sort of lingerie, is a very good lingerie, and or some toffee to the child, you get cooperation from the patient. So how remain calm in the final day? Never be late. Think whoever will come face boldly. Switch off the mobile. Don't discuss with friends. Sit comfortably with the selected area. Be confident, optimistic. Now, what are the absolute don'ts? Loitering, talking to co-examinees is a bad manner. Argument with the examiner should not be done. Hurting, overexposure of the patient should not be done. Unnecessary repeated touching the patient during the answering is absolutely bad manner. Start to tell without complete and listening is also very bad. So take home message. We have to be very smart, calm, and confident. We have to analyze the facts at every stage and try to explain. We have to listen carefully the questions, try to understand, then try to reproduce and start to tell. Be alert to provide the to the point and the relevant answer. This most importantly, the rules, either commit or the omit. If you are very sure, then only commit. If you're not sure, omit the point. This is the rule of the examination. Thank you.
Thank you, Paul sir, for beautifully explaining how to approach the practical examination. So there are questions. Sir, in real cases, how will you prevent the examiner bias? As generally, the practical examination are subjective based. So how do you prevent the examiner bias, both internal and external?
So this is very difficult to questions to answer this, because that is why we are here. As you are preparing, preparing this, this very wonderful stage for sharing our knowledge, so that every teaching learning is a dynamic process. So this PG course is not only for the teaching learning for the students, but also learning for the teachers also. So, and I feel the teacher should make a very consensus of opinion and consensus of the answers which should be required from the students. So this is very important. And sometimes the students may face some bias. Some teachers may have some preoccupied idea, so that I want this sort of answer. So what the intelligent student will do? The intelligent student will actually capture what the teacher is trying to get, and then according to this, if he is very clever enough, then he can catch the point, and then they can change his this line of management, and he can everything you have to explain, and he can. I already told, if either you have to commit or the omit. Don't have to. You should not quarrel. We should not fight with the examiner. So in this way, I think you can be easily take it out the bias, examination bias.
Sir, you are also examiner to DNB examinees. Can you give any special instruction to DNB examinee, because they have some different pattern than normal MS orthopedic? Their practical exams are generally away from the parent institute. So any special instruction for approaching the practical examination for DNB students?
Yes, that is why I kept these OSCE system, OSCE and the virtual case. All the DNB students, they have to face this OSCE system as also the virtual case. I already stated, in the OSCE system, always remember what is the time limit and what is the answer, what is the answer is asked for. So you have to give the very to the point answer. There is no scope of giving some large answer, large sentences like that. Very to the point answer to be given. Suppose what is the gate? Just you have to write. We have to get a specific gate. Again, if you are unable to spot the gate, then you have to describe the gate. That is the opinion. Suppose there are in some condition that some components of the train limb gait and the short limb gait may be mixed. So in that case, you have to write it is a bipedal unassisted gait, where having the component of both the short limb as also the train limb gait. So in this manner, we have to write the answer. And for the real cases, again, there are all the status of the cases are same. There is no long case and a short case in the DNB. So every status of all the cases are same. So we have to make sure about this. And what are the standard questions we have to face? That is, what is the provisional diagnosis? What is the differential diagnosis? What are the points in favor of provisional? What are the differential diagnosis? How do you exclude this? Now, how will you manage the case? Now, if you ask this question, there are 3 questions are embedded in it. That means, how will you confirm your diagnosis by specific investigation? How will you counsel the patient? And what is the line of management? So again, start in this manner. So this is the standard norms we are actually accepting in different examinations in DNB. So always be prepared for that. And lastly, the summary of the case. So always, in whatever the case you get, so be prepared for this very short summary, as I've shown this. It's a very short history for this 1 or 2 sentence, and for 1 or 2 sentences for the examination. This is extremely important. That will because that will help you to understand. That will understand to give the answers of the questions. What are the points in favor of your diagnosis? What are the points against? This is most important.
Sir, many students we face during Viva examination, especially those students who come from a small town, they are not able to properly communicate to examiner, but they have the proper theoretical knowledge. So do you have any advice to those students how to approach?
Yes, that is it is extremely important questions you have asked. Yes, some questions, and that is the COVID scenario. And most of the students who are coming from the different centers, which has been converted to the COVID center, so they didn't get opportunity to expose for many cases. So what is the way to get it out? So I am giving the very simplest way. Take any case, say make a list of the case, like what are the long cases, short cases. So in the long, suppose it's the tuberculosis, you didn't get sufficient cases of the tuberculosis of the hip. So in that case, you can simulate the case, and you present the different types. What are the normal findings if you get in a tuberculosis of the hip, and you can make a practice of telling that, sir, this is the summary in front of your peers, in front of your students, or in front of your colleagues, or in front of your just immediate boss. Even like simulating the case, you can start to tell in a manner. So this, sir, this is the case of this is the summary. Then you have to face the questions which is asked by your peers, by your friends, that what are the points in favor of a diagnosis, and the friends will judge you that this point is not going to become the perfect. Now this is the wrong. Only the practice. You know everything. You know everything from the book, but the practice, even if you see the case, this practice is extremely good for before appearing the practical examination. Simulate the case and practice to tell what is the case, what is the points in favor, like that.
Yes, Dr. Manish.
Dr. Manish allows, I want to question.
Yes.
Dr. A.K. Pal. Yeah, A.K. Pal, sir. Actually, I am also teaching the DNBs, but many of the times, sir, there are more finding in the standing or in supine that differs. So we should follow our presentation to near the examiner with the finding, according to the finding, or we should go first standing and then supine. What's that, sir?
Yes, it is a very important question you have asked. Suppose the level of the ASIS, level of the anterosuperior spine, which should be mentioned in which position? Suppose the anterosuperior spine position may be in a standing position, it may be in the same level as the patient is compensating by, suppose there is a short limb, the limb is short, and patient is compensating by equinus, that is a plantar flexion of the ankle. So the level of the anterosuperior spine is the same, but once immediately when the patient is examined in the supine position, now it has become evident that it is in the lower level. So what is the point to be tell in the examination? So in my opinion is, what are the points is relevant in this standing position, that has to be tell. So in my opinion, so I should not mention the ASIS in the standing position. What are the points to be examined in the standing position, which is very relevant, which cannot be examined in other position? That is most important. We have to identify. Suppose in the standing position, you have to tell what is the position. If you see from the front, side, and back, the position of the head, and then next the position of the shoulder, the scapula, the spine, next there's scoliosis, there's lordosis, scoliosis, lordosis, and any spinal deformity. And if there is any abnormality of the lower limb length, that is sufficient enough. So we need not examine, need not tell the ASIS, need not tell the wasting, because these are the several other positions which you can jolly well examine, and for this wasting like that. So we have to check it out. So in which position? So just we have to mention that every point should be mentioned, should not miss any point. So that is why I'm mentioning there are 3 points: attitude deformity, swelling, wasting, and skin. This is most important. So in any position, suppose the patient in standing position from front, we have to see what is the attitude and deformity, what is in the swelling and wasting. If there's obvious swelling, you can tell. Wasting is not needed. Then skin abnormality. If there's obvious scar is visible, you can tell. Otherwise, you can tell in the supine position like that. So it is unnecessary to take to mention all the points in all positions, in my opinion.
Thank you, sir. So in this scientific webinar, now I would like to invite Dr. Nirmal Kumar, Secretary, Jharkhand Orthopedic Association, to give vote of thanks. Over to you, Dr. Nirmal.
Thank you, Dr. Manish. On behalf of Jharkhand Orthopedic Association, it's my privilege again to thank all the faculties who are on board. Professor Lalit Maini sir, Dr. Anand Kishore Pal sir, Dr. Anil Bhat sir, and Dr. Tarun Goyal sir, for having spared their valuable time in spite of this being Sunday. And we are really, we have sincere apologies to make from the family of all the faculties for keeping them engaged even on Sunday night. At the same time, I must say that all the faculties could do real justice with all the topics given to them, and definitely we couldn't have asked for a constellation of faculties better than this. That's what my whole feeling after having witnessed and listened to all the listeners. At the same time, I would like to thank and congratulate at the same time Dr. Manish Ras for having taken so much of pain and organized this webinar so well. And definitely this would not have been possible without his vision and his efforts. At the same time, I would like to thank Dr. Birendra and Dr. Saubik Das for moderating the session so well, and for being pillar support to Dr. Manish Ras for conducting this webinar so successfully. I hope in near future, we will be again and again inviting our faculties who participated today, and they should be more than happy and eager to help us in this endeavor. And we also expect them to be physically present in future in our meetings and maybe our CMEs and annual conferences as well. So thank you everyone for putting up such a great show. And I must also at the end, last but not the least, thank Ortho TV for giving us this slot and giving this opportunity to organize this webinar. So thank you each and everyone. And I wish you all a happy Sunday or weekend, I must say, whatever time is left out. Thank you again.
Thank you, sir. Bye. Bye, sir. Thank you. Bye.
Thank you, sir.
Thank you.
Thank you, sir.
Bye.
So what's about